We are live on Facebook. So, Dr. Srivatsa, you can start with your presentation.
Yeah. Good morning, everyone. At the outset, welcome to the RCC Demystified program webinar today. And at the outset, I would like to thank Dr. Nitesh Jain, Dr. Tanuj, and the whole team of ULTOE group for having me here. I'll be starting the day's proceedings with what guidelines, the current guidelines say about management of RCC. Coming to the diagnostic evaluation, it has now become a fad that everyone is kind of using PET CT scan for staging cancers. However, the guidelines are quite strong as far as RCCs are concerned, and the current recommendation is to use a multi-phasic contrast enhanced CT scan of abdomen along with screening of chest for both diagnosis as well as staging of renal tumors. The key here is to use the triple phase contrast enhancement, that is to look at the arterial phase, the venous phase, as well as the urogram phase, which will have a treatment implication as far as planning a surgery is concerned, especially if you are contemplating doing a partial nephrectomy. Whenever patients have contraindications for usage of contrast, MRI is a very good alternative, and in select indications, patients can also be subjected to non-ionizing modalities like the contrast enhanced ultrasonography, the renal elastography, especially to discern small renal masses, as well as to understand the difference between a tumor thrombus and a blank thrombus. This is having a lot of traction in the recent time, the renal mass biopsy. Renal mass biopsy was not a standard procedure for the fear of tumor spillage, for the fear of bleeding, and for the fact that it would not probably offer much in terms of decision for us to much in terms of an indication to make a change in the way we manage the disease. However, in the recent past, renal mass biopsy has been increasingly done in the backdrop of the increased utilization of active surveillance, increased utilization of non-surgical ablative techniques. So there was a consensus panel which has given us recommendations of when to do and when not to do renal mass biopsies. So I'll just read one by one. Biopsy in the setting of ablation. Obtaining a biopsy is absolutely essential. Biopsy before or after cryoablation, prefer to do it always before, and in case there is a suspicion that there is a disease recurrence, a biopsy even after ablation is indicated. Renal mass biopsy is not indicated in patients who have evidence syndromic or monomorphic pathology, and when the imaging characteristics of these specific pathologies are very evident. When patients have other primaries, renal mass biopsies are recommended. When patients have prior renal lesions, again renal mass biopsies are recommended. And patients who are adopting, who are utilizing active surveillance as their treatment strategy, it is imperative for us to recommend renal mass biopsy. And whenever we are contemplating watchful waiting, that is whenever we are not offering any curative treatment, renal mass biopsy is not indicated. So these are the guidelines. Perform a renal tumor biopsy before ablative therapy and systemic therapy without previous pathology. Do not perform a renal tumor biopsy for cystic renal masses. Again, very, very important. The probability of tumor spillage, the fluid spillage is very high. There might be an upstaging of disease, and therefore it should not be performed. And whenever a mass biopsy is performed, it is important to use a coaxial technique to minimize bleeding, to minimize the potential of tumor spillage, and to have an enhanced tissue sample for a better diagnosis. Whenever a mass biopsy is done, it is important to obtain at least 2 full length cores, that is a core more than 1.2 centimeters in length, which is unfragmented from 2 different areas of the tumor lesion, which will therefore be considered representative. Coming to genetic counseling is indicated for all patients with kidney cancers who are presenting less than or equal to 46 years of age. It is also indicated in patients who have multifocal or bilateral lesions, who have family history suggesting an inherited kidney cancer syndrome, or in those patients who have another first or second degree relative with RCC, meaning to say that there is a higher possibility that it could be genetic in nature. And genetic counseling is also indicated in patients who have RCC with any other two associated syndromic findings during the imaging. That is, it could include a pneumothorax, fibrofolliculomas, leiomyomas, fibroids in female patients, patients who have had childhood history of seizures, or patients who have had pheochromocytoma or paraganglioma, or any of these combinations. Even if there are two of these associated findings, it is probably advisable to offer a genetic counseling. Coming to prognostic models, it is very, very important. This is seldom practiced. It's very important for us to adopt at least one of the prognostic model in risk stratification of a patient being under workup for management of RCC. We have several prognostic models. All of these tools are available freely online. And we have prognostic models for localized RCC, prognostic models for metastatic RCC. It's important for us to utilize at least one and document it at the onset of our evaluation. Coming to the management, surgery is by far the mainstay of management in organ confined RCC, or probably even locally advanced RCC. These are the levels of evidence. I'm not sure if my screen is blocked here. One second. Yeah. Laparoscopic radical nephrectomy has lower morbidity than open nephrectomy. It has got level 1B evidence, and therefore, whenever radical nephrectomy is contemplated, laparoscopy is probably the modality of choice, or minimal access surgery is the modality of choice. Short-term oncological outcomes for T1 and T2A tumors are equivalent for both laparoscopic and open radical nephrectomy. There is a level 2A evidence for that. Partial nephrectomy can be performed either by open, pure laparoscopic, or robotic-assisted approach based on surgeons' expertise and skills. And partial nephrectomy is associated with a higher percentage of positive surgical margins compared to radical nephrectomy. However, the level of evidence is weak for that. Coming to the recommendations, offer surgery to achieve cure in localized renal cancer. This has got the strongest strength of rating. Offer partial nephrectomy to patients with T1 tumors. Do not perform ipsilateral adrenalectomy if there is no clinical or radiological evidence of invasion of the adrenal gland. Offer an extended lymph node dissection to patients with adverse clinical features, including a large diameter of the primary tumor. The strength rating is weak. However, I think Dr. Ragavan is going to elaborate more on this in the subsequent talk. Offer embolization to patients who are unfit for surgery, presenting with massive hematuria or flank pain. Again, this is some a scenario that I would like to highlight here, that embolization should be offered only on patients at onset of symptoms. There are many situations where we find that patients have extensive disease who are not operable or who are not amenable for any other treatment. However, we should not offer embolization upfront at the time of diagnosis and reserve it to the onset of symptoms like hematuria, flank pain, or even paraneoplastic syndromes. It is also important for us to understand that whenever we contemplate doing embolization, pre-embolization renal mass biopsy may be preferable in case the patients become fit enough to receive systemic therapy in the future. Offer laparoscopic radical nephrectomy to patients with T2 tumors and localized masses not treatable by partial nephrectomy. Again, the strength rating is quite strong for this. This is again, the next thing is again very important. Do not perform minimally invasive radical nephrectomy in patients with T1 tumors for whom a partial nephrectomy is feasible by any approach, including open. So the key consideration here is, or the driver is, the oncological outcome, nephron sparing, followed by the access. So this order should not be altered. Oncological outcome is paramount, followed by the nephron sparing wherever possible should be done, and the access takes the third preference. Do not perform minimally invasive surgery if this approach may compromise oncological, functional, or perioperative outcomes. Coming to positive surgical margins in nephron sparing surgery. Positive surgical margins increase with T-stage and higher grade of tumor. Access does not impact positive surgical margin rates, though there is now weak evidence that PSM rates are higher with pure laparoscopic approach. Frozen section may not add to surgical decisions or outcomes except in complex tumor locations or in imperative indications. Therefore, we need not wait to get a frozen section report at all times when we are contemplating doing a partial nephrectomy. Positive surgical margin increases the risk of recurrence but has negligible impact on cancer specific or overall survival, and observation is recommended unless gross margin is positive. Coming to the recommendations on management of early RCC, offer active surveillance, radiofrequency ablation or cryoablation to frail and or comorbid patients with small renal masses. Amongst these three, active surveillance is now taking a lead role, with even patients who are apparently fit for surgery being offered active surveillance in select indications. When radiofrequency ablation, cryoablation and active surveillance are offered, it is mandatory for us to inform patients about higher risk of local recurrence and or tumor progression. Coming to treatment of locally advanced RCC, the recommendations are as follows. In patients with clinically enlarged lymph nodes, perform lymph node dissection for staging purposes or local control. The current strength rating is weak, but again, there is a lot of traction to this, and Dr. Ragavan will probably speak on this later. Remove the renal tumor and the thrombus in case of venous involvement in non-metastatic disease. Again, the strength rating is very strong, highlighting the fact that even in locally advanced situations, surgery is probably the best option available for these patients for a potential cure. Coming to adjuvant therapy in management of both localized as well as locally advanced RCCs who have probably undergone a R0 resection. There are several trials, 4 to be precise, of which only one trial has shown some favorable benefit. The EAU guidelines as well as AUA guidelines have extensively reviewed these papers, and these are the recommendations. In patients with clinically enlarged lymph nodes, perform lymph node dissection for staging purposes or local control. Do not offer adjuvant therapy. Remove the renal tumor. Yeah, so I think the slide has come back again. There is no strong evidence to suggest that patients with R0 resection, irrespective of the histopathological, adverse histopathological factors, to receive adjuvant therapy. Coming to management of advanced or metastatic RCC, to control local symptoms, offer ablative therapy, including metastasectomy to patients with metastatic disease and, most importantly, favorable disease factors and in whom complete resection is achievable. If you look at this statement, all points included in this statement are very, very important. The point number one that needs to be looked at is the favorable nature of the disease, even though it is metastatic. And even important is the ability to offer complete resection. So whenever ablative therapy is contemplated, the disease pathology should be favorable and complete resection should be achievable. This has been changed in the recent past after the availability of Carmina trial. Though the strength rating is weak, I think over a period of time we will try to understand what is the right way of approach in management of metastatic RCC. So the highlight here is that we should not offer doing a cytoreductive nephrectomy on all patients like what we used to practice before, and we should now select our patients for cytoreductive nephrectomy. Offer stereotactic radiotherapy for clinically relevant bone or brain metastasis for local control and symptom relief. So I would like to just highlight this IMDC risk model before we move on to the management of metastatic RCCs. IMDC, or the otherwise called as the Hemang's risk model, is based on several risk factors like the Karnofsky performance status, time from diagnosis to treatment, the baseline hemoglobin level at assessment, corrected serum calcium at assessment, initial assessment, absolute neutrophil count, as well as the platelet counts. So these are the cutoff points that are used, and based on these points, the disease is considered as a favorable disease or a favorable disease burden when there are no risk factors. That's very important to understand when there are no risk factors, intermediate when there are 1 or 2 risk factors, and anything beyond 2 risk factors pushes the patient into a poor risk factor category. So this IMDC model is now, or the MSKCC, either of them are now being aggressively used to understand how we manage advanced or metastatic RCC patients. So unlike the cytoreductive nephrectomy, which used to be the first line of management for all patients irrespective of stage of RCC, now it is predominantly medical, and it's getting complicated by the day, probably for the better, I would say, with availability of lot of immunotherapeutic drugs, as well as even advanced tyrosine kinase inhibitors, and as well as the other PD-1, PD-L1 inhibitors. So the current recommendations are to offer pembrolizumab, which is a immunotherapeutic drug, with axitinib, which is a TKI, to treat for treatment-naive patients with any IMDC risk clear cell metastatic RCC. The strength rating is strong. However, subsequently, probably in the subsequent talks, we will understand how to actually risk stratify and offer cytoreductive nephrectomy in select patients. Offer ipilimumab and nivolumab to treatment-naive patients with IMDC intermediate and poor risk clear cell MRCC. Here you can see that the TKI has been replaced with a second immunotherapeutic agent, meaning to say that the disease is aggressive, so we need to be more aggressive in treatment. Administer nivolumab plus ipilimumab and pembrolizumab. So you can see here that there are several trials which have shown results by adding more and more drugs upfront, predominantly immunotherapeutic drugs. I will not go into the full details of this because it's outside our domain. But one thing that I would like to highlight here is that sunitinib and pazopanib still are, a part of first-line management, who are probably not fit enough, or who are probably will not receive immunotherapeutic treatment. So this is the treatment model for as a first-line therapy in advanced and metastatic RCC. This has been updated in 2020. So if you look at the IMDC risk model, patients with favorable risk model, with the standard of care currently is a combination of pembrolizumab and axitinib, or pembrolizumab alone or axitinib alone. In patients who are not fit enough to receive immunotherapy or this combination, the alternative is to either initiate patients on sunitinib or pazopanib, which has a favorable side effect profile. In patients who have IMDC intermediate and poor risk features, the standard of care is to use pembrolizumab or axitinib combination, or ipilimumab with nivolumab combination. The second alternative is to use cabozantinib, sunitinib, or pazopanib. This is the current recommendation for later line therapies in advanced or metastatic RCC. Patients who have priorly received immunotherapy as their first line of treatment, the standard of care is to use any VEGF targeted therapy that has not been used previously in combination with immunotherapy. So this is the standard recommendation. There is unfortunately no alternative. We can probably go for second line immunotherapeutic drugs or third line immunotherapeutic drugs, but there is no guideline as such. Patients who had a prior TKI, that is TKI in the beginning of their disease management, can be offered either single agent nivolumab or another TKI with cabozantinib. The alternative is to use another TKI, axitinib. So these are the recommendations, the summary of recommendations. Offer nivolumab or cabozantinib for immune checkpoint inhibitor naive vascular endothelial VEGFR refractory clear cell metastatic RCC, which has got a strong strength of rating. Sequencing the agent not used as second line therapy. For third line therapy is recommended. Like I mentioned before, there is no alternative as such. There is no recommendation as such. The strength rating is weak. It is left to the discretion of the treating doctor. Offer cabozantinib after VEGF targeted therapy in clear cell MRCC. Sequence systemic therapy in treating MRCC. For patients with recurrent RCC, the current recommendation is to contemplate offering a surgical resection of a locally recurrent disease, especially when a complete resection is possible and significant comorbidities are absent. Coming to the follow-up, again, it is all based on the nomogram. Base follow-up after RCC on the risk of recurrence, looking at the nomogram. Intensify follow-up in patients after nephron sparing surgery for tumors which were T2 in nature, or in patients who have had a positive surgical margin, though the strength rating recommendation is weak. Base risk stratification on pre-existing classification systems such as the, like I mentioned, the UCLA integrated staging system or the S-sign score. The strength of recommendation is strong. So this is the last slide. This is the NCCN guideline. One slide which will tell us all about the management of RCC, starting from the initial workup to the follow-up. Thank you very much.
Thank you, Dr. Srivatsa. Yes, we will start with Dr. Ginil's presentation. Ginil sir, can you come online, please? Yes. Yeah. Please start your screen, sir.
Am I audible?
Yes, sir.
Can you see my?
Yeah, we can see the slides. Yeah, it's clear, sir.
I'm Dr. Ginil Kumar. I'm at Kochi at Addla Institute of Medical Science. Is there any disturbance in the background?
There is a little bit of disturbance in your background, sir, but it's still you're quite clearly audible to us. We are seeing the slides changing.
No, I cannot change the slide. That's why just. Yeah. I'm Dr. Ginil Kumar. I'm from Addla Institute of Medical Science, Cochin. So topic which I am going to discuss is diagnostic challenges in RCC and the role of biopsy. Srivatsa, Dr. Srivatsa has given a good background for my discussion. I'm just discussing a lot of issues based on a few cases. And I'll be going a little into the role of biopsy because Dr. Srivatsa has already discussed. So all the diagnostic challenge happens because of some diagnostic dilemma in the evaluation or the pathological uncertainty and issues related to planning the treatment. These are because one, more and more small renal tumors are now diagnosed, and a lot of them may be benign. The pathology has progressed to such an extent, and genetic abnormality is seen in a lot of cases. And over and above to that, there can be some confusion because of inappropriate investigations and issues with the diagnostic finding, investigation finding. So the profile of RCC has changed, and more incidentally detected tumors are seen nowadays. Still, around 17% are advanced, and the triad of symptoms are seen only in less than 10% nowadays. If you go through the details of presentation, we can see that when the size of the tumor increases, the chance of hitting a malignant tumor also increases, and less the size, more having a benign pathology. So all small renal monster, are they safe? No, exactly. I'll just discuss with the help of a few cases. You can see that in the literature, around 3% of individual less than 4 centimeter can be metastatic, and we don't have much idea how we can actually select these patients and avoid active surveillance for these patients. So this is a 44-year-old gentleman presented with a small renal mass, but he had a chest pain, and there was some haziness in the chest. You can see that this is the haziness which is seen, and this is a metastasis to a rib from the small renal mass. So all small renal mass are not safe. Again, you can see that there's a small renal mass around 2.5 centimeter, and the tumor thrombus was extending up to the atrium in another patient who was a 52-year-old lady. So small renal masses, they are not always safe, and you cannot avoid a treatment or postpone the treatment if it is possible. So another question is whether CT, is it CT or MRI which is preferable? As Dr. Srivatsa has rightly pointed out, CT is the gold standard. And current CT is almost comparable with MRI in all aspects. Even the advantage for CT is it is good in evaluating the arterial anatomy before surgery. But it is difficult to assess the histology. But there are some patterns we can recognize and come out with some idea about the pathology. So another question is whether we can diagnose AML in small renal mass, which is the main category of benign pathology. MRI gives an edge over CT in this area. And oncocytoma, probably a renal nuclear scan using sestamibi may be useful. More trials has to happen on this. This is based on a small study. So MRI has got advantage when there is contrast allergy or in pregnancy. When there is when the pathology is AML, which is suspected, especially in a small renal mass, it is comparatively better with, for venous thrombus, but current day MDCT is almost comparable. And it is having some advantage in the evaluation of cyst. And there is a new wing that is coming up, is radiomics, to assess to diagnose the pathology based on the investigation finding in radiology. I'll just go through a case scenario where the investigation or radiological assessment is very important. This 61-year-old male with history of smoking presented with an incidentally detected 3 centimeter hyperechosis on the right side. The diagnosis was hemorrhages, but they commented that there is some solid component inside, advised CT. So CT, this was the doubtful cyst. You can see the cyst here. Only factor is it is completely embedded in the parenchyma. We cannot assess the wall. Cyst is to be an innocent cyst. But since the ultrasound showed some solid component, we did a MRI. MRI also showed some solid component, but there was no definite enhancement in contrast enhancement. Again, we are novel. So again, question is whether clot or tumor. So one investigation which is not used much is the contrast enhanced USG, and current EAU guideline recommend that we proceed with that. You can see that this tumor is enhanced in contrast when contrast was given. And this is a tool which can be used and has got better detection rate, especially in equivocal cystic masses, and is recommended by the EAU currently. So we proceed with the robotic partial nephrectomy, and the pathology was clear cell tumor grade 2 format. But story doesn't end there. He was on follow-up. After 2 years, he's presented with hematuria. There was a scar in the site of resection. There was equivocal enhancement according to the CT from outside. Radiologist review from here showed that he is not very happy about the enhancement, needs a MRI. MRI, actually you can see that the area was normal, but opposite renal hilum, there was actually a small lesion according to the radiologist. So we evaluated. Cytology was atypical cells was there in the cytology, and flexi-URS was there. That confirmed that urothelial tumor in the opposite kidney. We did a nephrouretectomy. So after again he had an episode of hematuria, this time low-grade bladder tumor, and he is on mitomycin currently, and present creatinine is 2.2. So it is very important to assess with appropriate investigation in the not only pre-op, in the post-op also. Another issue is with the Bosniak classification. You know that Bosniak classification is one classification which stood against time for more than 30 years. So this Bosniak says 3, 4, and 2 can actually make a lot of confusion, diagnostic dilemmas. So this girl, she was studying in her PUC, 16-year-old girl, presented with a complex cyst. And you can see that is some of the radiologists told that is 3, some told that is 4, Bosniak type 4. So, and this is highly complex cyst, but even though she was 16, since you can see that there are some septations inside with probably solid nodule. So we proceed with a robotic partial nephrectomy for this patient. Whether a biopsy can be done, as rightly told by Srivatsa, in cystic mass, it has to be avoided. And is more than 4 centimeter, type 3 or 4 cyst, no other option, we proceed as partial nephrectomy. And the pathology came as tuberocystic renal cell carcinoma. Issue is a lot of newer and newer entities are coming in the pathology. This is actually a good prognostic, comparatively good prognostic tumor. And as Srivatsa rightly told, in all patients below 45, it is better to have a genetic counseling. And we did a gene evaluation. It has fumarate hydratase gene mutation. So 2 points I want to highlight is the importance of genetic evaluation. Second, even in young girls, we cannot neglect a cyst if it is type 3 or 4. FDG PET, is it indicated? It is not recommended in primary evaluation, but it has to be used in re-evaluation of doubtful lesions, not as a routine base. This patient actually had a renal mass around 8 centimeter, and he had some non-specific pain in the leg. So we evaluated with a PET scan. It showed a small uptake in the humerus where there was no symptom. We are confused whether we have to go behind that. Should we avoid a surgery? But he was a good prognostic candidate. So according to guideline, even if they metastasis, there is a role for cytoreductive. So we proceed with nephrectomy. And according to radiologists, this can be nuclear orifices, can be just a false positive because this is the area where inflammation can occur. So we reevaluate after 6 months with a PET scan. There was no lesion, it was vanished. So a primary evaluation with PET scan in renal tumor sometimes can cause confusion like this. But when it comes to a doubtful lesion, in the re-evaluation on a doubtful lesion, what happens? This patient had a partial nephrectomy 2 years back, then had clear cell carcinoma. After 2 years, he developed an adrenal lesion. We are planning for an adrenalectomy because we, on evaluation, that was the only site of metastasis. But we proceed with the PET scan. PET scan, apart from the adrenal, there was some activity in the mediastinum. So we discussed with one of senior doctor at MD Anderson how to proceed, because if it is a false positive, if you are avoiding adrenalectomy, it is not good. If it's a positive, we are doing adrenalectomy because already the opposite adrenal is gone because it is an upper polar tumor and the adrenal was removed along with that complex tumor. So this patient underwent a transesophageal ultrasound guided biopsy, showed clear cell RCC mets in this lymph node, and he is on TKI now. So appropriate investigation in the follow-up is important. Re-evaluation with with the FDG PET scan in doubtful lesion is important. So regarding pathology, the renal cell carcinoma, is a chunk of multiple pathologies. Around 75% can be VHL, and RCC is a heterogeneous disease, as you know. So the biopsy aspect already Srivatsa has discussed. It has to be a coaxial technique where the chance of seeding is very low. Bleeding is an issue with the biopsy. So biopsy is safe and also it is accurate. But why it is not routinely used? Because it can be inconclusive in 10%. When there is a cystic lesion, it may not be useful, and in majority of the cases, it's not going to alter the outcome. As you know, in the largest study, you can see that the accuracy is very good. We also had a small study which shows the accuracy of a biopsy, but we had two negative patients in biopsy who had, one among had a malignancy. So we cannot avoid a treatment. Then there was no change in the management by routine biopsy in this patient. So a biopsy is not indicated routinely, but in where biopsy will be done. This is actually a small renal mass in a solitary kidney. If the patient don't want to take the risk of a partial nephrectomy and nephron loss, probably a RFA or a cryo is an option in this posterior renal tumor. And in that case, we have to do a biopsy because we may not get a tissue later for pathological confirmation. Should we do a biopsy for all active surveillance patient? Since the tumor is there, we can do a biopsy at any time. Active surveillance in largest trial did not recommend biopsy for all the patient, but if a doubtful lesion is there, we have to go ahead with the active biopsy. So in metastatic tumor, already I discussed, biopsy is indicated because cytoreductive nephrectomy is currently done only in rare patients, only in good prognostic patients. So again, lady having history of fever and flank pain. This is the lesion, and CT reported as a T4 renal tumor, which was the renal tumor going outside the into the musculature and crossing up to the subcutaneous level. So since she had a history of fever 2 weeks back, we thought of putting in a needle and we aspirated pus. And a drainage was done with a pigtail. Long-term antibiotic was started, but again, she had to have an INT, and biopsy came as inflammatory lesion. So this is the importance of biopsy. Now, doubtful lesion, even though it is not recommended routinely, in doubtful lesion, we have to. So again, this patient, 48-year-old male, bilateral renal tumor, but when the CT was evaluated, I was surprised. There were 12 lesions in right side, 6 lesions in the left side, and there was no history of any family history of renal tumor. So I was surprised whether it can be a metastasis from elsewhere, or if a renal tumor is metastasizing to all other areas. But since the so we thought of having 2 tests. One is a PET scan and a biopsy. Biopsy was clear cell RCC, and PET scan did not show any extrarenal. So with the possibility of multiple primary in the tumor, 12 in the right and 6 in the left, we proceed with the partial nephrectomy because we cannot go for a bilateral radical if possible. So we did a genetic screening. There was no VHL, but what we saw was a tuberous sclerosis mutation, TSC gene mutation, which was seen in, again, I am reiterating what Srivatsa has told. When there is multiple tumor, it is better to have a genetic evaluation. So this is the tumor, 12 tumors from left side. So what I want to highlight is, even in very complex cases, we can avoid a nephrectomy. Only thing is, we may not go for pathological cure is more important, and cosmetic or other non-invasive techniques. So it is rightly told by Srivatsa. I'm again quoting his words. So indication for biopsy is when we are suspecting an inflammatory mass or lymphoma or suspecting metastasis, or in RCC, if you are planning for an RFA or a cryo, or before a TKI as a part of neourgent or as a part of a metastatic treatment, or when active surveillance, but in active surveillance, it's not mandatory. So guideline or algorithm for planning a biopsy is, if you are suspecting lymphoma, or if a patient is a candidate for active surveillance, or if ablation is planned, or if the patient is willing to observe a benign lesion, which is the probable diagnosis in biopsy, then we can go for a biopsy. If there is a clinical benefit or to histological assessment, then we can plan. Otherwise, there is no role for a routine biopsy, and patient treatment team willing to accept risk of biopsy, we can go ahead with the biopsy. There is no routine biopsy in RCC. So these are the area where you can have diagnostic dilemmas. Second, I would say enumerating the role of biopsy in the current practice. All these points actually Dr. Srivatsa has discussed, so I'm not going. Thank you very much.
Thank you, sir, for that excellent talk. Can I request Dr. Sanjay to please come on? Yeah. Ginil sir will take up the questions at the end of all talks.
Okay. Good morning. I'm Dr. Sanjai Addla. I'm a urologist, uro-oncologist, and robotic surgeon in Apollo Cancer Institute, Hyderabad. Many thanks for this forum to invite me for giving this talk, and I'm thankful to Dr. Thomas Guzzo. I've used some of his slides. There is going to be a bit of overlap between what has been said by Dr. Srivatsa and Dr. Ginil and what I'm going to suggest, but I'll just try to summarize what they were trying to say, mainly with respect to the screening element. So,
Dr. Sanjay, please share your screen.
Is it not coming?
No, it's not.
I thought that's the first thing I did. Okay, just a minute, sorry. Share screen. This. Coming?
Yeah.
Okay. Okay, so just to thank Dr. Thomas Guzzo, who some of his slides have used in this presentation. Okay, so let's go through this. I've divided the active surveillance into two parts. One, an imperative or an absolute one. Ginil has already mentioned a couple of cases wherein active surveillance would be appropriate. I'll just try to see where it becomes an absolute necessity. And then the relative one, which is patients who are elderly or infirm, where you would consider it. So let's go for the first one. The reason why I have included epidemiology here is whenever things don't fall in line with what is expected, you have to expect the unexpected. So what I mean by that is, when you look at the peak incidence of renal cell carcinoma, it is around 60 to 70 years. So whenever a 20 or a 30-year-old is presenting, you got to think why, okay? And again, if you see male to female ratio is 1.5:1. Again, you would think that genetically, probably if the females younger is presenting, then there is a higher probability they might be carrying a genetic syndrome. Okay, so just to highlight that the peak incidence of renal cell carcinoma is 60 to 70 years. So when would you do genetic screening? These are the two guidelines that are available, and I'm just trying to decrease the size. Okay, these are the two guidelines that are available. So when you look at it, there are 4 factors. The first factor is the age, which is less than 50. The second is bilateral or multifocal. Third is family history. And then the fourth one is non-clear cell histology. So whenever these 4 features are there, you got to consider whether you would do a genetic screening or not. Okay, so let's see this. So these are the 4 factors. I'm just sorry. Okay, so this is fine. So these are the 4 factors that we are talking of. When you look at the age as such, this is from the CA database, overall CA database. That's what I was alluding to. So when you look at the normal presentation of RCC, the peak is at 62 or 70 years. Whereas when you look at the hereditary one, it is almost less than 40. So where do you draw the line with respect to age? Probably less than 50. Whenever a patient is presenting, consider genetic screening. That's one. Second, family history. This is a bit of a variable one because family history is depending on how big is your family. If you are a nuclear family and you don't know anything about anyone else, you would say that there isn't any family history. So when you look at lifetime risk of renal cell carcinoma in United States of America, it's 1.6%. However, when you look at a family, a small family, number is 8, there is a 12% risk of a positive family history. A bigger family, there is a 20% risk of positive family history. So yes, family history is important, but you got to ask in the second sentence, saying how big is the family that we are talking of. The third one, non-clear cell histology. So when you look at the chances of there being attributable to hereditary, when you say clear cell RCC, it is less than 5% or around 5%. The moment it becomes papillary, there is 6%. And then when it go down the line of medullary, almost 100% of the time, it is associated with sickle cell trait. And when you look at AML, around 20 to 30% of them could be genetically. So that's the reason. So when we looked at the age, less than 50, second was the family history. The third is non-clear cell RCC. And then the fourth one is multifocality, especially the one that Dr. Ginil had mentioned. Whenever somebody is presenting like that, you know that that is a genetic hereditarily. So around 3 to 5% of all RCC can be bilateral or multifocal on initial presentation. But when you look at in a specific detail, 3% of bilateral tumors who had previously VHL will have bilateral or multifocal compared to less than 5%, less than 1% with unilateral. When you look at the family history, 6% of patients with bilateral masses have family history compared to 3% with unilateral. And then the third one, papillary versus none, 19% of bilateral renal masses, at least one papillary RCC versus 12% with unilateral. So it again goes back to those 4 factors. Age less than 50, the second one would be non-clear cell RCC, the third one would be multifocality or bilateral lesions, and then the fourth one is family history. So these are the 4 patient cohorts whom you need to consider doing a genetic workup. The reason why it matters is how do we apply it in management of this patient? There is something called as a 3 centimeter rule. 3 centimeter rule is you keep them under active surveillance, because though these patients present early, quite often they tend to recur, but they have an indolent course. Often, I'm not saying that all the time. There will always be exceptions. Okay, so these tend to have an indolent course. So active surveillance until the mass exceeds 3 centimeters in size, and then you go and excise all the lesions, then you reset the clock, and then keep them on active surveillance. So this 3 centimeter rule can be followed for the patient. So if a patient presents with multifocality, you do genetic screening and you tend to note that they have got a syndrome. In that situation, you can put them on the 3 centimeter active surveillance and then operate when they start growing around 3 centimeters in size. Where does it apply? The reason for the genetic screening is this. So when you look at von Hippel-Lindau or hereditary papillary RCC or Burghardt-Dubé, you can apply the 3 centimeter rule. Where you cannot apply the 3 centimeter rule are these. So that is the reason for doing the screening. So if you pick up that there are SDH related RCC, you should not be putting them on the 3 centimeter rule. So this is where active surveillance and genetic screening, so that you know the syndrome, and that's how you manage them actively. Okay, then we come to the active surveillance in the elderly cohort of patients. Who are the patients we are talking of, and how does it differ? AS is different to watchful wait. You do have it around this 80 to 90-year-olds whom you're just keeping an eye on them because they are asymptomatic. AS is different in that you are keeping it similar to the prostate cancer. You're keeping an eye on them so that in case if there is a sign that this is an aggressive variant of it, you're going to go and intervene with the intention to cure these patients. Okay. Patients who are on borderline, somebody who has got a coronary artery disease, you want to keep an eye on them until they become probably fit, or they deteriorate and they become unfit for anything. So in those sort of cohort, you can keep them on active surveillance. So this is the second cohort of population where active surveillance is relevant. So let's look at active surveillance for T1 patients. These would be the questions: what scans to do, when do you consider active intervention, as in when do you consider it as progression, What is the rate of growth of this? Do they develop metastasis? Do they die of the cancer? And what about, we always say that, oh, patient has got mentally he became unstable, that's why we had to operate. So let's ask this question in a properly counseled patients, what is their psychological status? Okay, so let's try to answer. I'll try to answer those questions by the end of this talk. Okay, I've got around 4 papers that I'm going to quote. Whenever proof of principle in any sort of cancers tend to start off from the CA database, just because there is an ongoing collection of database, so you just need to query the database and you might have some answers. So in this one, they looked at T1A renal masses, so 4 centimeters or less, and then they compared active surveillance to thermoablation, to radical nephrectomy, to partial nephrectomy. So they did the 4 things: active surveillance, thermoablation, partial nephrectomy, and radical nephrectomy. I'm going to ignore the thermoablation because that's not the topic. So this one was there. And when you look at the numbers, these were propensity score matched. When they had active surveillance with partial, they had 1,354 patients in each cohort. When they looked at active surveillance versus radical nephrectomy, they had more than 1,600 patients in each arm. Okay, and median follow-up was around 4 to 5 years. Okay, so this is what they compared, and I'm only comparing it to active surveillance to partial nephrectomy, active surveillance to radical nephrectomy. When you look at the OAS, overall survival, and CSS, cancer specific survival. So when you look at the active surveillance versus radical nephrectomy, and you look at overall survival, you would think this is a database. This is not a randomized controlled trial. So you would think that patients who went down the line of active surveillance, I understand their propensity score matched, but they would be slightly fitter compared to patients who are on active surveillance. So that's why there is a difference when you look at overall survival. But when you look at their cancer specific survival, if you look at, we are talking of 140 months, comparing active surveillance to radical nephrectomy with a large cohort of population, there isn't any difference in the cancer specific survival at almost 12 years. Okay. When you look at active surveillance versus partial nephrectomy, there is a difference in the overall survival, and you would expect that there is a difference in the cancer specific survival as well. However, what you got to understand is we are comparing no intervention at all to a partial nephrectomy, which does carry complications with it. So this is cancer specific survival. One thing to notice, at around 12 years, around 90% of the patients are fine following active surveillance. Okay, so following active surveillance, around 90% of the patients are fine with respect to the cancer death, and those are the numbers. So when you look at the numbers, overall survival at 9 years, when you look at active surveillance versus partial nephrectomy, there is a difference, but the difference is 6%. Okay. When you look at active surveillance versus radical nephrectomy, overall survival, there is a slight difference. But when you look at cancer specific survival, again, I was quoting numbers upwards of 95% we are talking of. So cancer specific survival in a T1 renal cell carcinoma, the majority of these were histologically proven. T1 renal mass was 95% with active surveillance, 97.4% with partial nephrectomy. And when you look at radical nephrectomy, they were the same. So this is the SEER database one. There will be huge number of biases that will be involved, because these are only, what they're doing is they're mainly looking at what is the practice and what is the indication of what is happening. So it isn't a randomized control trial. So let's look at some of the data. This is a single institution data looking at patients who are above 75, and again comparing active treatment to active surveillance. So 537, very good number. 53% of the patients had partial nephrectomy, 30% had radical nephrectomy, 20% had active surveillance. And again, if you remember in the previous one, I said radical nephrectomy is same as active surveillance with respect to both cancer specific survival. Okay, so they are the same, radical nephrectomy even at 12 years. I think the reason for that is because of the renal failure impairment that tends to happen with radical nephrectomy. The impact on overall survival is also more. That's why it pulls it down towards active surveillance. Median follow-up 3.9 years. Overall mortality was 28%, the commonest being coronary arterial disease, not renal cell carcinoma. Cancer-related mortality was 4%. And again, overall survival. This is a single institution treatment. This wasn't a randomized one, a single institution observational study. Overall survival similar between radical nephrectomy and active surveillance. And I'm quoting papers from Cancer and Lancet. So we are not talking of some tiddly study in a Chinese paper. Okay, let's look at this one again from Cancer Journal. This was meta-analysis of all active surveillance paper. And again, you would think if it is published in Cancer, it is a good enough meta-analysis. Overall, though there might be hundreds of studies, they could only find 6 studies that was worthwhile to be mentioned. Okay, and what these numbers are quite interesting and good to follow, especially if there are any trainees. If you look at the mean size at presentation, 2.3 centimeters. This is expected to 15 centimeter cube. Linear growth rate. So I was asking, one of the question was, what is the rate of growth? 0.3 centimeters per year. If you were looking at tumor growth, 6.3 centimeters cube per year. 22, around a quarter of the renal masses did not have any change over the follow-up period of 33 months. Okay, when you look at the results, what were the patients who needed active treatment? Active treatment was given overall in the 30 months follow-up to 45% of the patients. However, 50% of these needed treatment mainly because the patient preferred, not because of any growth. So when you have the answer saying that what percentage of the patients need active intervention because of tumor growth, it's only around a quarter of the patients. Tumor growth was 2.2 centimeters in the ones who were on active surveillance compared to the ones who were going for active treatment. Metastasis, overall 2% metastasis. There was no metastasis in the cohort which did not have any growth. When you look at the who were the people who metastasized, the initial tumor size was bigger and the rate of growth was also bigger, 0.8 in the ones who metastasized compared to 0.3 in the ones who did not metastasize. This is the best study to do, which was not randomized, but a prospectively collected data on quite a large cohort, almost 500 patients who were patient preferred. So they were given both the options and the patients chose it. And what do we know from this one is how to follow these patients up. So all the patients had cross-sectional CT at the outset, then 6 monthly ultrasound scan for the first 2 years, yearly ultrasound scan following that, any rate of growth more than 0.5 centimeters, any size more than 4 centimeters, or any hematuria. Then they had another cross-sectional CT, and either they went down the line of treatment, active intervention, or went back into the same observation protocol. So the 2 questions are answered in this. What is the follow-up? Follow-up is based on ultrasound scan every 6 months for the first 2 years, every yearly after that. Rate of growth more than 0.5 centimeters, you intervene. Size more than 4 centimeters, you intervene. Or hematuria, you intervene. Okay. What were the outcomes? 9.4% of the patients went down the line of active treatment during the follow-up. The follow-up was short, but not significant. And when you look at overall progression, only 2.7% had progression. And overall survival and the cancer-specific survival is the same for both the cohorts. Overall survival, apologize, active treatment is slightly different because you would think there is a difference in which patient cohort, because we know when we looked at the baseline cohorts, the patients who went down the line of active surveillance were elderly. When you look at cancer-specific survival, active treatment versus active surveillance, it's the same. Okay. Psychological status, again, they studied in the same study, there is no depression or anxiety-related problems with active surveillance. Conclusions, what scans and when to do: 6 monthly ultrasound scan for 2 years, then yearly. When do you consider active treatment? As I said, any symptoms, any growth more than 0.5 or any size more than 4 centimeters. What is the rate of growth? Commonly, it's 0.3 centimeters per year. Do they develop metastasis? Yes, around 2%. Mainly the ones who are bigger than 4 centimeters at the outset or higher rate of growth, around 0.8 centimeters per year. Do they die of cancer? No, cancer-specific survival is the same. Psychological is none. So this is my talk about active surveillance. And in conclusion, we take Hippocrates' oath, and he says, to do nothing is sometimes a very good remedy. And if you think that is a very difficult thing for you to do, that's what I've been doing all my life. Thank you.
Thank you, Dr. Sanjay.
Okay.
So we will start with Dr. Rahul's talk. And, we'll take up the questions in the end. So please stay with us, Dr. Sanjay. Welcome, Dr.
Am I audible, I guess?
Yes, you're audible. We can see the slides.
So, good morning, everyone. Myself, Dr. Rahul Yadav, I'm Senior Consultant, Apollo Hospital, Lucknow. My topic is a little debatable, partial nephrectomy or enucleation, and how long is actually long when counting one ischemia. So I'll be discussing points and counterpoints for each, and later on a conclusion. So coming to the trifectas of partial nephrectomy, three important things we have to remember. First of all, we should achieve a negative cancer margin, functional preservation of as much renal parenchyma as possible, and to avoid complications. The primary determinant of renal function outcomes is renal parenchymal volume preservations. We have seen over the years from the era of radical nephrectomy for all RCC, partial or enucleations. The limited ischemia usually play a secondary role. Concerning a long-term GFR, the pre-operative GFR and renal parenchymal preservation correlates well with the long-term GFR. Usually the ischemia time influence creatinine and GFR in a perioperative. Let's come to the brainstorming critical thinking. We all know more renal parenchyma we preserve, it is always a better thing. But does this have any objectivity to it or not? So there are very two good papers concerning a mathematical model in which the group from China and Taiwan did a study, and what would be the post-operative functional reduction before partial nephrectomy. The same group has published another paper in 2016. Both the papers are from Journal of Urology. And then they correlated the renal function after partial nephrectomy. So to understand a little bit more, first of all, we need to know what is enucleation and what is a partial nephrectomy. I guess we all must be knowing it. In partial nephrectomy, we used to remove a rim of normal parenchyma. So it is a resected volume along with the renal mass, while it is not there in tumor enucleation. And with the rhinorrhaphy being done in partial nephrectomy as well as sometimes in enucleation, there is always a ischemic volume by rhinorrhaphy. So they make a mathematical formula in which we have to understand first few dimensions. Then I'll be discussing each scenario one after the another. So what they say is we have to calculate the depth of tumor from this renal surface. This is one dimension we have to calculate. There is another dimension which is a sum of resected volume and a ischemic volume. So the resected volume is in partial nephrectomy specimen and the ischemic volume is because of rhinorrhaphy. We put this into a formula, resected and ischemic volume, and in which we have to put down the width of resected and ischemized area, depth of a tumor involvement, and radius of a tumor. So this is the first scenario, when the tumor is predominantly exophytic. So this is a 6 centimeter tumor. It is 1 centimeter from the depth of the renal surface. This is a 5 mm rim of ischemized volume due to rhinorrhaphy. While there is one more 5 mm rim, which is because of the resected tumor. So when we put everything into the formulation, there is a 12 ml, 12 cc of volume being lost in case of enucleation. And in case of partial nephrectomy, the volume lost is something around 33 ml. If we calculate an average volume of the kidney being 200 cc and average GFR of the kidney 45 ml, then with a 6 centimeters predominantly exophytic tumor, in enucleation, the GFR lost is around about 2.88 ml, and while a partial nephrectomy GFR lost is 7.53. This is if we calculate preoperatively. Coming to the same tumor, the size of the tumor is same, that is 6 centimeters. The tumor is majorly endophytic. So this depth is going to change in the formula, which comes now to a 4 centimeter. Rest everything is the same. So when the tumor is going endophytic, the amount of renal volume being lost with a partial nephrectomy is 99 cc as compared to the 44 cc in enucleation. So if we again calculate the GFR lost with the same tumor, which is majorly endophytic, is 9.77 ml, and with the partial nephrectomy, GFR lost is 22.27 ml. What if the same tumor is purely endophytic? The whole of the tumor is inside. So the dimensions are all the same, but the depth is going to change now. The depth is now 6 centimeters completely inside. Rest of the parameters are all same. So with the enucleation, the volume roundabout lost is 63 cc, and it is 143 cc in case of partial nephrectomy. If we calculate at average volume and average GFR in the same scenario, the GFR lost is 14.37 ml in case of enucleation, and in case of a partial nephrectomy, it is 32.27. Well, this is an hypothetical scenario. Some can ask that we can remove a 2 mm rim, 1 mm rim, in which the results might be same. Yes, it can happen. But you know, this thing gives an objectivity to what we are saying, the amount of loss of GFR in partial nephrectomy versus enucleation. There are few limitations of this study. There may be volume errors. The tumor is not exactly a circle. It may be a different size. The compensatory hypertrophy of other normal kidney taking care of the GFR. There might be a parenchymal atrophy of affected kidney because of so many reasons like warm ischemia and everything. So let's take all the scenarios with each and every perspective. First of all, with the guideline perspective. And the guideline says the reference standard is nephron sparing surgeries, and there is no randomized data available to suggest one technique is better than the other. So both fares well in case of guidelines. EUA guidelines has already been discussed, the partial nephrectomy to be offered for T1 tumors. There is a paper being quoted just above the recommendations that simple tumor enucleation also had similar progression-free and cancer-specific survival compared to partial nephrectomy. The study being quoted has analyzed 982 patients of PN with 537 patients of simple enucleation over a period of 10 years and found that the results of both are same. So guideline perspective, anything can be attempted. What is the historical perspective? If we see the history, initially we used to do radical nephrectomy for all cases. Gradually in imperative indications for hereditary tumors, multifocal tumors, usually the partial nephrectomy pitch into. And in such cases, enucleation is the initial modality. Then the technique has extended to T1A disease, then to T1B tumors, and eventually to laparoscopic and robotic surgeries. While the partial nephrectomy group advocates there should be an ideal malignancy model, when we are following a margin of normal parenchyma or normal tissue around any tumor, so why not this? Possibility of positive surgical margins is always there in case of tumor enucleation. I have already discussed the functional preservations and the gray areas. As the objective mathematical formulation, it says that there is definitely an advantage of healthy parenchyma being attached to tumor enucleation. While the partial nephrectomy group advocates the decline in the function after partial nephrectomy is multifactorial. And it is not only the maximum renal preservation which matters, and the all important factors which affects the decline in renal function are currently under the investigation on a molecular level, and maybe in some time we'll get the answers. Pathologies do have a concern. I mean, for a tumor enucleation, the group advocates there is always a fibrous pseudocapsule in most RCC. There is a histological changes at the tumor parenchymal interface, which may vary from sclerosis at any levels. Even in case of pseudocapsule invasion, there is a thin microscopic layer of normal tissue with signs of lymphoplasmocytic inflammation in between the pseudocapsule and neoplastic cells. So even if there is a breach of pseudocapsule, the chances of positive margins are less. This is what a tumor enucleation is. There is a different idea of a partial nephrectomy group, which says that the dissection plane is not reliable in all tumors. The 5% tumors do lag pseudocapsule. Even when the pseudocapsule is present, it is not uniform and can be as thin as 0.2 mm. 30% of the clear cell tumors have an incomplete pseudocapsule. Therefore, just to adhere to the dissection plane may expose tumor, may facilitate entry into the mass. Coming to the surgical aspect of it, since there is a natural cleavage plane between the peritumor pseudocapsule and renal parenchyma, an anatomical dissection plane is always being taken care of. So this is histological, oncological safe, and also the chance of hemorrhage is less. Indeed, there are chance of positive surgical margins, but it is very less. And different groups have found out that in series of enucleation versus standard partial nephrectomy, it is the same or maybe even lower in some tumor enucleation series. The opposing group of partial nephrectomies do say that when they evaluated a series of clear cell renal carcinomas, they found that 1/3 of the enucleation specimens are actually true enucleations. More specimens are more like a enucleoresection, meaning some amount of tumor parenchyma is removed along with the tumor. So the data is actually blurred between a standard partial nephrectomy and an enucleation. Does 1 or 2 or 3 mm of surrounding parenchyma qualifies as enucleation or traditional partial nephrectomy? It's a debate. It's debatable. Coming to the oncological safety, with tumor enucleation, with the improved imaging tools, pseudocapsule can easily be ascertained. And these group advocate the significance of a microscopic positive margins in small renal masses is always a matter of debate. So why we are worrying so much for a small microscopic positive margins, even if it comes for in a tumor enucleation patients? And infiltration among a pseudocapsule layer is correlated well with the clinical pathological state, presence of histological necrosis and nuclear grade. So if we are anticipating a high clinical stage, more of a tumor necrosis, though nuclear grade is very difficult to ascertain preoperatively. But yes, in such cases, we can definitely go for a partial nephrectomy. Partial nephrectomy group same advocates that pseudocapsule can be invaded. For larger tumors, for papillary histology, there is high chance of invasion of pseudocapsule. And with increasing expertise in nephron sparing surgeries, we have to regard enucleation with caution, especially in large tumors. And positive surgical margins do have a deleterious effects on risk of recurrence in case of large tumors. Oncological data in tumor enucleation group, there are many retrospective studies which says good oncological results, same recurrence-free, cancer-free survival. While the partial nephrectomy group advocates that these series are mostly single institution studies without long-term follow-ups, no standardization or lack standardization. There is selection bias. Majority are for small renal masses. Outcome for large and more complex masses is largely unknown. Coming to the closing remarks and take-home message on tumor enucleation and partial nephrectomy. tumor enucleation meets all the criteria, is oncological safe, functionally conservative, and is key to expanding the indications for kidney sparing surgery, especially in complex cases. Tumor with intact pseudocapsule in imaging can be taken care with tumor enucleation. Highly complex renal tumors like large or centrally located tumors should be done with tumor enucleation. It is especially beneficial for synchronous multifocal ipsilateral renal masses. AUO guidelines do suggest that for certain familial multifocal tumors, this is the modality to go ahead. And maximum nephron sparing surgery techniques like tumor enucleation should be advocated in select circumstances. And they urge caution for routine use of tumor enucleation in all cases. Just a brief touch of warm ischemia benefits and the issues associated. We all know what is the benefit of a temporary occlusion of renal artery. It reduces bleeding, rigidity of renal parenchyma is reduced, improve visualization. Issues with warm ischemia, we don't know the tolerance of human kidney exactly to warm ischemia. The association with AKI, CKDA, and complications. We all know the mechanism of renal damage. Initially, it's a vascular, then obstructive, then a reperfusion. What are the types of warm ischemia? One is off-clamp zero ischemia, no clamping of renal artery. Another is early clamping, unclamping, meaning that after resection of the tumors and taking a first layer of medullary suture, we close the PCS or maybe a second layer of cortical suture if needed later on after unclamping. Some groups have advocated a selective clamping, in which case there is a hilar dissection. We go to the supply of the tumor artery and they just clamp that artery. Also, there is a pre-operative super selective transarterial embolization. So these are the various methods of warm ischemia. In animal models, what has been studied, 30 minutes to 120 minutes, this is a time frame when there are changes happening, irreversible changes happening in the kidney. Coming to the human model, there is a very interesting paper by Parekh DJ in which they did study 40 patients undergoing partial nephrectomy. They did renal biopsy before, during, and after ischemia. What they found out is very, very important. 30 to 60 minutes, only mild structural changes and no acute functional loss. But yes, there are limitations to the study, limitations to the group. The type of kidney preoperative GFR, all these are limitations to it. So this is the very important study which actually try to flaw that the warm ischemia of less than 30 minutes is not, which is always advocated. The real studies which shows that 30 minutes is the ideal time, they are studies from 1983, which studies renal ischemia while doing a nephrolithotomy or maybe a pillar lithotomy and identifies that cellular degeneration starts at 30 minutes. So 30 minutes is the safe time. So basically what sets the warm ischemia clock? Based on mainly animals and less of human historical experience, a maximum normothermic ischemia of 30 minutes had been traditionally recommended. This is a level 3-4 evidence basically. Whenever a long ischemia time is expected, surface cooling, medullary cooling to 15 to 20 degrees may allow you to work for 16 to 70 minutes more. There are various studies on renal ischemia during partial nephrectomy in solitary kidneys. What the inference from such studies is the short-term renal and long-term renal functions actually depends on 3 parameters: the pre-operative renal function, amount of healthy renal parenchyma, and warm ischemia time. So it is not just a warm ischemia time which matters. Even the recovery from the warm ischemia time matters. How the kidney is, whether the patient is having a little amount of CKD or it is a very good kidney. So there are different studies which evaluates the techniques of early clamping, no ischemia, or selective ischemia. None of the available ischemia techniques are superior to other. No difference in studies when warm ischemia time kept less than 30 minutes. But there is a concept of selective clamping without hilar ischemia is interesting. And this approach has associated with encouraging results. But the series are relatively small. They included selected patients treated by surgeons with significant experience. have relatively short follow-ups. What is the take-home message for warm ischemia? Renal function recovery after partial nephrectomy is associated with preoperative renal functions and also the amount of renal parenchyma preserved. If there is more of a renal parenchyma preserved, the chances of recovery is always good. Current evidence suggests that warm ischemia correlates well, as I discussed. There are level 3-4 evidence from several studies and only few human studies, which says that 20 to 25 minutes represents the most accurate cutoff. Usually the prolonged warm ischemia time should be avoided, but important paper from Parik suggests that with good kidneys, even they can tolerate up to 30 to 60 minutes of warm ischemia. But that's not advocated for all the cases. Whenever a longer ischemia time is anticipated, cold ischemia should be used. And the preliminary data with selective or no ischemia is associated with good outcomes, but obviously that has to be taken with a pinch of salt because additional studies are required. And these groups do usually have a good surgical experience prior. The animal model of 30 minutes does not correlate well with human models. Evidence highlights the tolerance of human kidney is better, especially when the baseline quality of renal ischemia, quantity of renal preservation is more. So in the end, what I want to tell is a good surgical craftsmanship is vital, rather than just counting the clocks to 25 to 30 minutes. Thank you.
Thank you, Dr. Rahul. We'll move on to Dr. Nitesh Jain's talk. Dr. Nitesh, you're on, please.
Good morning, everyone. Well, today I'll be speaking to you about robotic partial nephrectomy for complex tumor and tips and trick. I'll go straight to the business. What makes a tumor complex? There are various factors. First of all, it is the patient factor, like patient having various comorbidities like diabetes, hypertension, patient having some cardiac issues, patient taking medication like anticoagulant or antiplatelet. That all can make a surgery complex. The risk of anesthesia can increase, but the tumor per se does not change. Like uh, conditions like diabetes, hypertension, sometimes can increase the adhesibility of the fat or the gerotas onto the kidney, and it may increase the dissection more tricky. The other factor is the vessels. Vessels, the anatomy of the vessels, like early branching, multiple vessels, atherosclerotic vessels, all can give technical challenge during the dissection or the hilar dissection. Even the thick lymphatics at times can pose difficulties to dissect the hilum. But here we are going to discuss more about the anatomical factor, the tumor factor, which actually poses difficulty during the surgery. I'm not going to go into details of each and every nephrometry score, but basically from all the nephrometry score, what we infer is any tumor which is endophytic near the PCS or to the hilum and more centrally located are more complex as compared to a tumor which is peripherally located or towards the pole of the kidney. So how to deal with them? Basically, we need three things: a good instruments or a good armamentarium in our bucket, good imaging to know how the tumor is in relation to various structure and its vasculature, and a good experienced team. Coming to each of them. So basically, if you are talking about robotic, definitely we need a robotic instrument. The next is your vascular clamp. Scanlon clamp or a small bulldog clamps are very helpful in case if you're planning for selective clamping, then probably we may need small clamp in the form of aneurysmal clips. Drop-in ultrasound is very useful, especially if you are dealing with endophytic tumor where the location and margin of the tumor has to be delineated. And next is your firefly. This is the new baby in the town where we usually useful in case we are planning for selective clamping we can selectively clamp the vessel and see whether the tumor is still being supplied or not. Sometime in case where the vascular anatomy is not very clear, or we don't know whether we have completely clamped the vessels or not, in those cases also we can use ICG dye, and then probably we can know whether the kidney is being perfused or not. The next is a good imaging. Good imaging always helps in any form of surgery, and especially if you have a good 3D reconstructive image, then probably we can do the surgery very well. We can plan the surgery. Here we can see the tumor lying posteriorly, say ectopic kidney to tumor lying posteriorly with the vessel supplying right from the branch of the vessel, and this patient was managed by robotic partial nephrectomy. So coming to the technical consideration or the experience of the surgeon, first of all, we should decide whether the partial is needed or not. If it is needed, then technologists should not decide whether we should go for a partial or radical. The next important is for any form of partial or any surgery, a good consent is necessary, and in case of partial, conversion to open or radical nephrectomy should be taken. A good assistance is boon in any surgery, and especially in robotic surgery, a good assistant that is bedside to the robo is very, very essential, because he does major bulk of the work like suctioning, clipping, and change of instruments, everything. Stenting or RGC is personal preference, but for all complex tumor where I feel I may open the PCS system, I usually prefer stenting. Use of technology, again, it all depends, especially in case of endophytic tumor, where the tumor is very centrally located. A drop in ultrasound is very useful, and firefly technology can be used, as I have told earlier. Warm ischemia time, it all already Dr. Rahul have said a lot about it. I am not going to go into detail. Vessel clamping, again, it depends on surgeon to surgeon. Usually I clamp only the artery, but both artery and veins are clamped in case of hilar tumor. My preference to clamp both artery and vein in case of hilar tumor when the tumor is very near to the major vessels. Bolster or hemostatic, again it is a personal choice. I usually don't prefer using any bolster or hemostatic agent for my partial nephrectomy. Suture, again, usually for the inner layer I usually use the 2-0 Stratafix running suture, and for the outer layer a 2-0 V-lock sutures. Rhinography again is done in 2 layers. Coming to the position of the patient, it is the patients are positioned in the standard flank position, which we usually use for a nephrectomy or partial nephrectomy, laparoscopy or robotic. We are using XI robo right now, so usually most of the ports are in line position, that is on the lateral border of the rectus in a single line, and the assistant port is usually placed in the mid umbilical to epigastric region. The first basic step of the surgery is colon mobilization. We should not compromise on mobilizing the colon. So in case of left side, the colon should be mobilized right from the iliac vessels up to the spleen. The spleen should open just like a book. It should fall medially. Especially in case of upper pole tumor, splenic mobilization very important, and also in case of posterior tumors. So the next step is hilar dissection. So a good traction onto the ureter is very essential. Usually I prefer dropping down the gonadal on the left side, and I don't touch gonadal on the right hand side. So once the gonadal are dropped, most of the time you escape dissecting the lumbar vessels, and looping of the vessel is not necessary in all cases, but here we can see the artery is lying in between the 2 veins, so it is necessary to help in clamping, or in case any untoward event happen, we can clamp the arteries. So the next step in case of partial nephrectomy is demarcation of the tumor. We need to open the gerotas all around the tumor. A good chunk of normal functioning kidney, normal kidney should be seen all around to make our sutures effective. And at no point of time we should actually reflect the capsule, because capsule is the main thing which holds the stitches. So coming to the tumor resection is, once we have clipped the vessel, here we are clipping only the artery, not the vein. So once we have done that, it's always better to start from the side which is nearer to you. If possible, we can make a complete we can encircle the tumor completely by making sharp cut, and sharp cut is useful rather than using cautery. Cautery may the line of demarcation may get deviated with use of cautery. So it's always better to use sharp cutting. The next step is your rhinography. So inner layer is usually done using Stratafix, and it's better to suture only the medullary part of the kidney. In case if you have opened any pieces here, we can see it should be sutured and closed properly and separately. All the rhinography is done using a sliding clip method, and the next layer is usually done in a continuous. I prefer doing in continuous method, but there are various other methods like using a interrupted sliding clip technique or making horizontal method. So it all depends on personal choice. I usually prefer for all my cases a continuous suturing. So coming to my first case, complex tumors. So here we can see a tumor which is lying very close to the vessels and the PCS on the anterior hilar lip. Probably these are the simpler of the complex tumor. So again, the basic step remains the same. So once the colon is mobilized and the hilum is dissected, both vein and artery are clamped separately. So here we have dissected the hilum, and the gerota is being opened now. We can see the renal lip or the sinus here, and it is very close. The tumor is just lying on the renal lip. We are marking the tumor all around. The vessels, in this case, there are two arteries, both are clamped separately. Since the tumor is very close to the sinus, even the vein is also clamped, but you can remove the vein once you do the inner layer. Many people actually remove both artery and venous clamp after doing the inner. So the early clamp removal is possible, but it all depends on surgeon comfort level. I usually remove the venous clamp, not the arterial clamp. Any small vessels which is entering the tumor can be clipped separately, or they can also be sutured separately when we are doing the inner rhinography. In case of very tumor which is very close to the PCS system, we should err on the side of opening the PCS rather than preserving the PCS, because a oncological negative outcome is more important than anything else in case of cancer surgery. So once we are done with that, the inner rhinography can be done using continuous suture using 2-0 Stratafix, and the outer layer again can be done using V-lock suture continuous layer. We should always observe the kidney at least for 5 minutes when the clamps are removed for any bleeding or anything, because sometimes the vessel can be in spasm. So we need to see all that. Coming to the next case is a upper pole tumor, upper pole posterior tumor. We can see the tumor lies very close to the hilar vessels. Again, in this, the basic steps remain the same. The colon is mobilized, the hilum is dissected. Here we can see the tumor lies very close to the hilum, and need to be dissected properly. It is here in this case, like in the earlier case, we didn't mobilize the kidney much, but here we need to mobilize the kidney well. And since the tumor is very endophytic, we need to use a drop-in ultrasound as well. The tumor is marked using an ultrasound probe, and once that is done, the hilar vessels are clamped, both artery and vein. Here we can see the tumor is just going inside the sinus. The tumor is resected, cut all around using a sharp cut if possible, or you can also make a horseshoe cut initially, lift the tumor, and then combine the margins at the end. So once that is done, the inner layer needs to be sutured separately using a 2-0 Stratafix. Any opened vessels can be sutured. Here we can see the open vessels can be sutured separately, and if you have opened PCA, that also need to be tackled during this point of time. Once that is done, the outer layer can be done. Here you can see the hilar lip. The hilar lip was very thin. We are not having a opposite parenchyma. We can take running suture here this also helps in reducing the bleeding or prevention of the bleeding. Once that is done, we can tackle the outer layer using a continuous suture. In this case, we have used 20Y for the outer rhinography. So instead of V-lock, we can also use. So once that is done, we can see a well-preserved kidney and good amount of parenchyma which is left behind. The next cases, probably these are more complex cases. A posterior hilar tumor, of all the location, probably this is one of the most complex or challenging location, a posterior hilar lip tumor. Here we need, here the basic steps again remains the same. Once we are done, the kidney mobilization is the key here. We need to completely flip the kidney, unlike in the upper pole tumor where we do a vertical tilt or a longitudinal tilt. Of here we need to completely flip the kidney. We can see the tumor lying here posteriorly on the posterior hilar lip. So once the vessels are clamped, we need to flip the kidney again back completely, so that we see the posterior surface. Many people do it in little different way, either by a retroperitoneal route and all, but I am more comfortable at doing this. Here the main important thing what we have to see is, whatever we are doing, we are using sharp cut of the scissors. We never use cautery here, and the tip of the scissor usually is directed towards the kidney rather than onto the tumors to prevent going inside the tumor. So in case if renal sinuses are there, they can be peeled off easily, and again the kidney is sutured closed in 2 layers. So these are the basic few steps for complex partial tumor in different location. So what are the tips and tricks? We should have good armamentarium or almost all the tools which are available to help us doing complex cases. A good bedside assistance is very much essential. Stenting or RCC, it all depends on surgeon's choice, but in complex tumor, at least a RGC should be kept to know whether we have opened the PCS or not. Adequate mobilization, we should not compromise on mobilization of the bowel, kidney, or anything for that matter. And it is always easier to resect from the area which is nearer to you rather than going from an area which is not near to you. Always it is better to have a wider base rather than a shallow base, because a wider base is easier to close as compared to a shallow base. But here many people may argue you may take a little extra normal tissue as well. Defatting of the kidney is very much essential, and we should not peel off the capsule at any stage, because capsule only holds the stitches onto the kidney, and tumor near the hilum, vein clamping may help at times. So last but not the least, conversion to open is not a failure if deemed necessity to do partial, but just doing a radical for the sake of using the technology is not at all justified. Thank you.
Thank you, Dr. Nitesh. Dr. Ragavan, you're ready with the presentation, sir?
Hi, I'm just skipping the video off purposefully.
Okay.
Hello.
Yeah.
So I'll share the screen to start the presentation.
Sure.
So the question that has been asked to me is the lymph nodes, whether to do lymph nodes or not. So I'll try my best to answer those questions. Am I audible? And is
Yes,
the
sir.
screen
Yes.
is the screen clear?
Yeah, we can see the screen.
Okay.
Yeah.
Okay. So I'm Dr. Ragavan. I'm a senior consultant in Apollo Hospitals, Chennai. So today I'm going to discuss about the lymph node dissection for RCC. So we are going to try and answer these questions. Why lymph node dissection? Which subset of patients should we do? What is the surgical template? Morbidity associated with it? And are there candidates who can be predicted before so that they can be included for the lymph node dissection? And what are the current recommendations? Yeah. So these are the facts and figures. Lymph node metastasis is found in 4 to 32% of the patients. Clinical stage and pathological grade really determines whether there is lymph node metastasis or not. And lymph node mets are a prognostic factor rather than influencing the survival. The patients with lymph node positive disease, the chance of 5-year survival is less than 30%. And in a metastatic RCC, all of us know is less than 20% in 5 years. The lymph node metastasis rates increases with these risk factors. When it is a ferment grade 3-4, sarcomatoid tumors, tumor size more than 10 centimeters, pathologically T3, T4, and tumor necrosis in the specimen. So if you look at the risk factors and see what is the percentage of lymph nodes in a retrospective series, you will see that as the factors increase in size, the chance of node metastasis also increases, meaning you can be comfortable that if you don't have a large tumor, then you probably don't need to do lymph node dissections for them as well. So let us go through as which subset of patients should we do lymph node dissection. So we had a good randomized control trial looking at low risk disease, finding very clearly, it's an EORTC trial which clearly said that absolutely no advantage in doing lymph node dissection as a bottom line for every RCC. So if you have a low risk disease, a tumor size 6 centimeters or even 7, you don't need to completely go and do lymph node dissections for all of them. Okay, let's go to the high risk disease but localized RCC. So more than 7 centimeters. Once again, if you look at lymph node done patients versus lymph node not done patients, node positive patients always had a worse outcome, but just adding the lymph node dissection did not add to the survival. So it looks like it is more a prognostic rather than a therapeutic intervention. Now, in T3 disease, if you look at the propensity score analysis done, radical nephrectomy with lymph node dissection does not increase the cancer-specific survival or overall survival in PT3 disease patients. So in metastatic setting, patients undergoing cytoreductive nephrectomy, yes? And in those patients as well, the oncological outcomes, namely cancer-specific survival, did not change much with addition of lymph node dissection. So a meta-analysis, Bimal Bindi's meta-analysis came in BJU with a reasonably good meta-analysis, which clearly showed that the incidence of lymph node metastasis is about 8% at the high, but there is no advantage of doing that dissection. So once again, it is pointing towards more a prognostic rather than a therapeutic intervention. In the metastatic setting, of course, the lymph node metastasis is also expected to be very high at 33%. But once again, it didn't add to the cancer-specific survival. Forest plot, once again, reiterated the same. In a node-positive patient, that is, you are going to look at the CT and say that there are enlarged lymph nodes. Once again, adding lymph node dissection did not improve the ontological outcomes. The problem is that many of these things are looking only at CSS and OS. There is no study, none of the studies has discussed about the local recurrence and symptoms related to that. That is not discussed at all. It is like the prostate cancer T3 disease, which always is recommended to have radiation, but nobody, because in relationship to overall survival, but nobody will discuss in any of the papers the symptom related to radiation in a T3 disease. So like that, we don't have any discussion on the symptoms related to lymph node dissection. So in N1M0, 12 studies, 5-year cancer-specific survival is 39% at the best. OS outcomes are very similar to cancer-specific outcomes as well. Prognostic value of N1, the presence of radiographic or pathological lymph node metastasis was independently associated with increased mortality. But once again, doing a dissection did not add to the survival of the patient. Now, in case you are considering surgical templates for lymph node dissection, this is what the templates are. So it is both the anterior and posterior in right side. So imagine everything related to the great vessel, in and around the great vessel, up to the medial aspect of the opposite great vessel. That's a trick you need to think about. In right side, it's paracaval, inter-aortic caval, and retrocaval. and in the posterior paracaval, retrocaval, interaortic cable, and up to thoracic nerve. The same way. So everything around the aorta up to the medial aspect of the cable. So if you look at right side disease, the majority of them are having metastasis in the pre-cable and retrocaval area, and there is nothing lateral to the great vessel. That is, if you look at the right side, nothing lateral to the or left of the aorta. If you look at the left side, then there is nothing right side of the vena cava. So the extent of lymph node dissection, typical Robson's technique, start from the crest of the diaphragm up to the great vessel division. So you have to take everything and anything around it. Predominantly infrarenal aspects, infrarenal vein aspects are the one which is very important to be covered. But remember, you have to go up to the floor of the diaphragm. Is there a morbidity associated with lymph node dissection? Actually, there is not much of morbidity. In my experience of doing many patients lymph node dissection, what I've observed is if you do it on the left side, there is definitely a slightly higher chyle output in the drain lasting for 7 to 10 days, which is inevitably well managed with just somatostatin injection. As long as when you're doing the dissection, you use liberal amount of clips and not just do a bipolar, but do a liberal amount of clips, a metal or a hemolox. They usually, the chyle discharge is self-limiting and stops. But if you're going to just remove the lymph nodes without clipping it, then the chyle discharge lasts for long, including chirosositis as well. Thankfully, so far, I haven't had a patient like that. There are predictive models available. There are a lot of, this slide will tell you that there are nomograms to predict the lymph node, presence of lymph node metastasis, and these are all available for people to use. So, where are the current guidelines at this point of time? It is to offer extended lymph node dissection to patients with adverse clinical features, including large diameter of the tumor. The strength of this recommendation is weak, and definitely to do lymph node dissections in enlarged nodes as a staging and local control. My personal take on this matter is that even though there is no distinct survival advantage in doing lymph node dissection, as the scientific evidence is, I tend to do lymph node dissection in patients with enlarged nodes, and as well as in adverse features such as 12 centimeter, 10, 12 centimeter tumor, or there is a lot of tumor necrosis within the tumor on the CT scan. So these are patients I tend to do lymph node dissections. Thank you.
Thank you, sir.
Let me stop share screen. Just
I can do it from here.
Oh, cool.
Yeah, that's that. Dr. Hemang, sir. Yeah. Dr. Santosh, it is Dr. Hemang's topic before you. Dr. Hemang Baxi, sir, are you on me?
Can you?
Yeah, I can hear you, sir.
Can you see the video? Because
no.
It says you can't start your video because the host has stopped it. So you have to.
No. I'll start it, sir. I'll have to ask you to start. Yeah, I can see it.
So
please share your screen, sir.
Yes, please. Moment. Can you see the?
Yeah. I can see the slides. Yes, slideshow has started.
Okay, so first of all, a big thanks to Dr. Nitesh and Dr. Tanuj and the teams the Alto for having me here. And I will be speaking on venous thrombus in RCC and how far should we be chasing it. Now, just to have a look at the classification, we all know there are different levels of venous thrombi. The NCCN and the AGCC 2017 8th editions mentions that T3 disease, a T3A thrombus will extend into the renal vein or its branches. A T3B is any involvement below the diaphragm, and T3C is above the diaphragm. Now, the Mayo Clinic classification is different. T1A is, level 1 is up to 2 centimeters of the renal vein. Level 2 is infrahepatic. And level 3 is above the hepatic vein, and level 4 is above the diaphragm. Now, the question is whether these levels of thrombi have got any prognostic significance, whether the outcomes of level 3 and level 4 thrombi tend to be worse in terms of cancer-specific survival. Well, the evidence is marginal. They tend to have a higher complication rate because of the complexity of the surgery, but in absolute terms of cancer-specific survivals, the outcomes are not that different as could be expected. Now, the key question, I have addressed this in 4 parts. 1, what should be the proximal level of thrombus which we can and should be doing safely, surgically? How should we do it? What is the evidence for it? And does a couple of things help, like neoadjuvant medical therapy or angioembolization? And to start with, chasing the thrombus, the heart was made to be opened to change Oscar Wilde's statements, but it should be chased beyond the heart, right up to the pulmonary artery, as we can, I'll be able to show you in a few slides subsequently. But the answer is simple, that whenever you have a non-metastatic renal cell carcinoma with a venous thrombus which extends all the way up to the heart in a fit patient, you should be operating on him. Now, this is the reason why you should be operating on him, because if you look at the survival rate, this is a little older data, up to 2004, but still, this is still quoted in Campbell's Urology, European Urology Guidelines even now. So the survival is as between 45% to 70%. So if taken all comers of all renal venous thrombi, which are non-metastatic, 45 to 70% cure rates, which is very significant, and which is the reason why we should be embarking on this surgically and attempt to do an R0 resection. How should we doing it? Certain key steps before I go on to discuss some cases. 1, the most important step, as Inder Birgil always highlights in all his talks, principle of thrombus first and kidney later. Always deal with the thrombus first, especially on the left side, where if the left, there is a caval thrombus on the left, you have to deal with the thrombus first and then come to the kidney, come to the nephrectomy. And first you can disconnect the renal vein if necessary from the IVC and tackle the left kidney later. Always get a proximal venous control above the thrombus. This is especially true in level 2 and 3 thrombi. Intrahepatic also, you need to first dissect out the superior limit of the thrombus, then have a vascular tourniquet across it, and then operate. And of course, all vascular instruments, sutures, tourniquet should be ready with your team. You should have a proper experience with you all times. And a vascular surgery team on standby if for any bypass, for any grafting of the cava or patching of the vena cava, or just simple torrential bleeding. If it happens, you can't control it, always have the vascular surgery team on standby. The other points are to mobilize the cava completely above and below the level of the thrombus, because you don't want a back bleed from the lumbar. So all the lumbar vein should be secured. Prepare for caval resection and grafting by a vascular team, as I already showed. For large right-sided thrombus, secure the artery first in the interaortocaval region. This is very important because some large renal tumors on the right side may obscure the renal artery. The vein is short. There is a large thrombus in the cava. The planes are not very good if you approach the artery in the traditional way, lateral to the cava. So best thing is to get it in the interaortocaval region, and that should be the first step. Now, while doing lap or robotic approach, have a low threshold for open conversion. Any big bleed from the IVC, just stop, and there is absolutely no shame in converting to open surgery. For open surgery, have a good self-retaining. I prefer a Thompson, but you can have any good retaining retractor which you have. Headlights are not an mandatory as in pelvic surgery, but they do help. So, according to the level of the thrombus, level 1 you can just deal with by an oblique vascular clamp across the cava. For level 2, you have vascular control above, below the thrombus on the cava. So you have isolated the cava above and below the thrombus, ligated the rhombus, and control the opposite renal vein. Now, for left-sided tumors, you can temporarily also clamp the right renal artery for fear of congestion because the renal vein is clamped. If the thrombectomy is going to last a long time, it's prudent to clamp the artery also temporarily. I don't do it regularly, but it can be done. For level 3 thrombi above, intrahepatic thrombi, you need complete lever mobilization and the Pringle apart from the level 2 steps. And for level 4, extending supradiaphragmatically, you can get away with a veno-venous bypass if the thrombus can be built below the atrium, or best thing is a cardiopulmonary bypass with complete circulatory arrest. That is the most relatively bloodless feel you get, and do the thrombectomy quite safely without fierce bleeding. So I'm temporarily going to exit because this video could not be accommodated, and I'll come back in a moment. So first of all, I'll show a few cases. This is a right-sided thrombus, and we have done this robotically in a 43-year-old gentleman. My preference is usually laparoscopic. This patient wanted a robotic. You can see the thrombus clearly, and we are tackling the renal artery here. You can see the thrombus extends right up to the junction. So there was a single renal artery which we secured between clips. Mobilize the kidney all around. Check if there are any small arteries, we can tackle that. And now you can see we are tackling the renal vein. Very little purchase here at the cava and junction of the renal vein. So, but the tumor does not extend into the cava. So what we tried is clipping this, 2 clips here, and then 1 at the top. Just to make sure, again, there are no other renal arteries. We again did some more mobilization, taking care of the renal vein then. And freeing the upper pole. Now, we milled the thrombus a little back and try to clip this, which we were successful in getting. And we started dividing the renal vein. Now, if you can see, the clip has started slipping. The clip is right across, applied completely. When I pull this starts slipping. So, because it is the specimen side of the clip, I'm not worried about very large amount of bleeding, but I don't want to spill the thrombus here into the surgical field. So just kept on isolating and dissecting more the side. Okay. So the assistant port grasper comes in through the laparoscopic port and grabs the leading edge of the vein. The clip is dislodged, we completely remove the clip. And then we suture up the edges. This is done to prevent the thrombus from slipping into the field. I think I'll stop this here. So sometimes these clips can be a little difficult, especially when there is no purchase. Sorry about this, but okay. For left-sided thrombus, now, if you can see, this is a large renal mass in a 28-year-old man and has a thrombus right extending up to the IVC. You can see here it is not extending into the IVC. An intraoperative view, this is the IVC and this is the tumor-laden thrombus extending right up to here. So first step is to mobilize the right colon and expose the IVC, cauterize the duodenum, expose the left renal vein. And because this is not extending into the IVC, you don't need to dissect on the right side, just staple this. So from the previous experience, we learned that if you can get away, the staple, a vascular staple 35 mm, works very well, and you can not only not have the fear of clips being dislodged, but you get a clean cut staple line on the IVC, and this is the left renal vein with the thrombus isolated. So then you can go back to the nephrectomy, mobilize the left colon and deal with it. Now for a level 2 thrombus on the left side, you need to control, this is the inferior control with a rubber tourniquet on the right renal vein. This is the vena cava below the renal veins. The upper tourniquet is here, and this is the tumor thrombus in the left renal vein extending across. Doing the cavotomy after ligating all the lumbars is quite safe. Should have a bloodless field, and make sure that the sutures are ready, and we usually use a 5-0 sutures, the Prolene sutures, to suture a continuous stitch, and the assistant keeps the suction all the time busy so that you get a bloodless field. And they are continuous sutures on the first, then gradually you release the clamps, first the superior clamp, and then the rest of the 3. So the cavotomy edges should be clear and visible at all times without any blood in between. I think I'll stop this. And this is the final suture line of the vena cava, as you can see. Up to 50% of the lumen of the IVC can be compromised without any adverse effect on the patient. The patient might have a little transient pedal edema, but that goes off within a short period of time. Now, this is another case where we had a thrombus extending the left gonadal vein, as you can see. It is a level 3 thrombus, and the interesting part was there was also a bland tumor thrombus below the below the tumor thrombus, below the renal vein. So it is not necessary to always remove the bland thrombus. You can, if there are good adequate collaterals, completely transact the cava out here, or this is the only indication where you can use a filter, or you can use the clip if you can, and proceed for a thrombectomy directly. So another large tumor thrombus, level 3. So the liver flip is very important for these cases, and these cases we normally prefer to do open surgically. You divide the falciform ligament and the ligament of teres, then go all the way, expose the cardinal ligament, the layers of the cardinal ligament and the triangular ligament on the right, and have the liver all the way up to the left and till you see the hepatic vein. So this is the right renal vein, this is the cava, and this is the liver flip. and try do a thrombectomy. If the hepatic veins are free of the tumor, you can apply a tourniquet here and then proceed for a thrombectomy. This is the way we should. If they extend up to the hepatic vein or even above, then this maneuver is a must, which is the Pringle maneuver. You clamp the porta. I prefer doing this rubber shot tourniquets, and this is the tourniquet across the infrarenal cava. Especially for these kind of thrombi, they are very challenging, large thrombus here, and you can see the tip very well. A transesophageal ultrasound is very useful, especially in those cases which extend like this. And here you can see that this is a huge thrombus, probably invading the wall of the vena cava. So in these cases, an MRI would be the best thing which you can do to gauge the invasion of the wall. And if that is so, you would have certainly have to have a vascular team standby to have a resection of the cava and a graft if needed. So sometimes you get these pulmonary artery thrombi. If they are small and in the periphery, you just leave them as they are. If you don't operate on them. But I had one case in a 43-year-old man where the cardiothoracic surgeon did with a level 4 thrombus with a pulmonary artery thrombus, and he removed both. So it was a major thrombus in a major pulmonary artery branch. The patient had suffered breathlessness for a few days, and then he underwent this surgery and did well. Now the incision for this level 3 and 4 thrombi normally is a rooftop incision or a chevron incision, which is extended as a median sternotomy in a Mercedes-Benz kind of incision, but a midline incision. We call this the post-mortem incision, of course, but then this is useful in patients who are thin, the median sternotomy and the median midline incision. This is easier to close and easier to open fast if any emergency arises. So on a cardiopulmonary bypass, this is the thrombus which you can see. This is the open left atrium. This is the pericardial cavity, and the vascular controls in the pulmonary, in the atrium and the aorta have been done. Now, if the thrombus can be milled to below the level of the heart, you can do a veno-venous bypass, and this is how you can apply tourniquet here, and pump the blood from here to here, so or through the femoral vein. So that avoids the problems of cardioplegia, and the surgery can be done on a beating heart if you can. Now, this is the first series published by Inderberg Gill, as we all know, 16 cases, and this was on the cover of the Journal of Urology, and demonstrating the level of the various tourniquets, the ligation of the short hepatic veins robotically, if you can do it. But there is one also good Chinese series where they have done quite a few cases, but not many large series have come. And Gill has, of course, updated his own data with more patients on these tackled robotically. But lesser mortals, like most of us, would be hesitant in operating this robotically, but open surgically, it is good enough. Now look at the literature and what it says. In all guidelines, NCCN guidelines clearly say that surgery is an option. Dr. Srivatsa has already mentioned that. Remove, these are the EUA guidelines, remove the renal tumor and thrombus in case of venous involvement in non-metastatic disease. The level of evidence is strong. So we should be removing it regardless of the level. So, and what is the evidence? Now, data is derived from case series. We don't have large randomized studies or large trials because the volume of tumor thrombi in RCC is about 4 to 10% of cases will present. And the thrombus was not associated with increased dissemination to lymph nodes or distant metastasis. So thrombus in itself, while presenting a surgical challenge, is not that adverse a factor when you compare it with lymph node involvement or metastasis. So we should be removing it, and all patients with non-metastatic disease and tumor thrombus and an acceptable performance status should be considered for surgical intervention, irrespective of the extent of the tumor thrombus presentation. So this is very important. Don't try to give other therapies because the surgery is risky. We understand the surgery is risky, but We also need to understand that the patient really has a chance of cure only with surgery. And if we are not confident of tackling this ourselves, we should be falling in a vascular team, but doing it nevertheless. Does pre-op angioembolization help? Well, there are a few studies which show some benefit, but this study and many others, I quoted just one, increased operative time, increased blood loss, increased hospital stay, and increased peri-operative mortality have been found. So we should probably reserve it in very large tumors with a bulky thrombus, especially on the right side. You can consider, we don't do it routinely, but you can, not that there is much benefit of it. Does pre-op medical therapy help? TKIs, they have tried sorafenib, other drugs, bevacizumab, and many others. Small series, disappointing results, always less than 10% significant downsizing in the tumor thrombus level. And you also have to balance that against the risk of not just the disease progression, but also the fact that the thrombus can embolize at any time and cause serious mortality risk to the patient if you don't operate in time. But one incidental case report in 2019 has been reported a level 4 thrombus in a 54-year-old woman completely resolved after EP and NIVO. Now this is new, of course, this is not a TKI, but there is one report which you can't extrapolate on really, but this lady was unfit, they gave EP NIVO and it resolved completely and they went ahead and did a radical nephrectomy subsequently. But that cannot be held as evidence. So by and large, avoid using medical therapy as a neoadjuvant setting just to downgrade the level of the thrombus. In conclusion, I would say that surgery remains the mainstay of treatment with potentially curable outcomes in all fit patients. All fit patients should be operated on regardless of the level of the venous thrombus. And we should be chasing the thrombus as high as it goes. But the goal should be to first control the thrombus above the level of the upper level. Start by doing what is necessary, do what is possible, and suddenly you will find that you are tackling these cases more and more with a great deal of confidence. Thank you. Thank you.
Thank you, sir. So we'll be moving on to Dr. Santosh's talk now. Dr. Santosh, are you ready?
Yeah, I'm sharing the screen.
Yeah.
Yeah, is it visible?
Yeah, Hemang sir, please stay with us. We'll be taking up questions after this. Yeah, it is visible, Dr. Santosh.
Okay, I'm starting now. All right. Good morning, friends, and a big thank you to Ultoe team, and also a big hello to my co-presenters and all people online. It's a privilege to be presenting. Basically, if you see the screen, it looks like a football field. I basically look at cytoreductive nephrectomy concept as a football match in which there are different players. Players are nothing but surgeons or medical oncologists who are trying to get the ball to themselves and try to get a goal. So we are not aware of who will get the possession of the ball, who will be treating the patient, and who will be taking the ball into the goal post. So let's see how we will go about it. But before that, for my trainee friends, we'll start with a little basics. So as you all know, the TNM classification is extremely important in diagnosing RCC and staging it. More so, the prognostic risk criteria, which is the MSK-CC and IMDC, is used to stratify patients and also to decide which treatment the patient would be getting. Now, if you look at the left side of the screen, there's a big center. That's the center of the pitch where the football match starts, and that's actually where the action actually starts. And I put three small circles there, each defining era of treatment through which the cytoreductive nephrectomy has gone through. So let us start with the first era, which is the cytokine era. Now, the notion of cyto-related to nephrectomy, removal of kidney and primary tumor in the face of metastatic disease was based on series of observation. First, patients treated with primary tumor in situ who underwent cyto-related nephrectomy fared particularly poorer. Second, there were case reports that demonstrated that small number of patients treated with cyto-related nephrectomy experienced regression of metastatic disease. Now, as a result of this, 2 randomized controlled trials were taken and done by Flanagan et al. And McKish et al., which showed a 3-month and a 10-month survival benefit respectively in patients who have undergone cyto-related nephrectomy plus interferon. Subsequent pool analysis also showed an overall benefit of around 5.8 months in patients who underwent cyto-related nephrectomy plus interferon. Now, these findings built the foundation for cyto-related nephrectomy as a treatment paradigm in patients with RCC and synchronous metastasis. Despite the proven surgical benefits, the mechanism of cyto-related nephrectomy is unclear. Postulated mechanisms, as you all know, are probable removal of immunologic sink, decreased production of cytokines, delayed metastatic progression, and also azotemia induced by nephrectomy, which can be beneficial to the patient. In fact, some of them have even gone on to say that because of the introduction of targeted therapy in the management of metastatic RCC, if we add cyto-related nephrectomy to these, then the 10-month median overall survival that I just spoke about could be extended to around about 40 months as well after inclusion of targeted therapies. Now let's move to the next era, that is the TKI era. This era was an era we saw a lot of trials which were either retrospective or prospective. In the retrospective trial, there were 3 prominent authors who looked into and re-evaluated the impact of cyto-related nephrectomy in TKI era, and they found improved survival, but their studies are retrospective and it is limited by inherent selection bias. After that, the prospective trials came, and we all know that 2 prominent trials come in front of us when we talk about retrospective trials. One is the Carmina and second is the Certime. Let's take the Carmina trial. In the Carmina trial, 450 patients with intermediate and poor risk confirmed clear cell renal cell carcinoma were randomized in 1:1 fashion to either nephrectomy followed by sunitinib arm or sunitinib arm alone. After a follow-up of 15 months, they found that the sunitinib alone arm was non-inferior as compared to the cyto-nephrectomy nephrectomy plus sunitinib. When it was clear that sunitinib alone could be thought about as a treatment modality in selective patients like intermediate and low group, which was selected in Carmina, the question came is how do we sequence this therapy along with the other treatment? That's when the Certime trial came in. Now the Certime trial, as you can see, it's again a randomized prospective trial, and it is designed to evaluate the significance of sequence of cyto-related nephrectomy and systemic therapy. It randomized 99 patients to either immediate cyto-related nephrectomy followed by sunitinib, and the second arm was sunitinib followed by deferred cyto-related nephrectomy followed again by adjuvant sunitinib. What they found was, 1, deferred cyto-related nephrectomy did not improve the 28-week progression-free rate. Second, with the deferred approach, more patients received sunitinib, and the overall survival was higher on an intention to treat analysis, although I agree that this finding was not statistically significant. And third was pre-treatment with sunitinib may identify patients with inherent resistance to systemic therapy before planned cyto-related nephrectomy. Now, these findings appear to build on the Carmina trial and indicate an opportunity to better clarify how the timings and initial results of systemic therapy can be integrated into decisions for surgery. Now, with this, it has been proposed that deferred approach to surgery may decrease cancer-related morbidity, reduce primary tumor size, and limit neovascularization, which subsequently decrease the surgical risk and morbidity. As you can see that each trial has got some criticisms. In Carmina, the investigators required around 8 years to accrue patients. They were able to accrue only 450 out of the planned 576 patients. That's around 78% only. That probably suggests either the clinician's lack of equipoise or the patient's own unwillingness to be randomized. Second, 43% of patients were poor risk. 17% of patients in combined arm never received sunitinib. 17% of patients in sunitinib arm underwent cytoretinal nephrectomy. There was significant crossover within the study, with a large proportion of patients assigned to sunitinib alone eventually undergoing palliative nephrectomy for symptomatic control. And there were also surgical intangibles such as no data availability on tumor size, extent of lymphadenopathy, renal vein or IVC extension, or adjacent organ involvement. With Certime, the accrual was again affected by several factors, including local regulatory decisions. Second, complexity of timing of surgery and systemic treatment. Second, they used surgical risk factors for eligibility rather than the WHO performance status. 18% of patients were ineligible, and both these trials used the MSKCC criteria rather than the IMDC criteria. Over a period of time, as the targeted therapy developed, it was proved that the superiority of nivolumab and ipilimumab over sunitinib in terms of survival and quality of life also limited the applicability of the results of both these trials. But what are the takeaways? The takeaway, especially of Carmina trial, is that the importance of identifying the correct therapies and sequence them on a case-by-case basis. Second, treatment remains multimodal, and trade-offs and patient preferences must be considered. Certime questions the rationale for upfront cytoretinal nephrectomy. And second, it does suggest that a subset of metastatic RCC patients will achieve maximum benefit by receiving systemic therapy as their initial treatment. Now we move into an era which is the immune checkpoint inhibitor era. Currently, as you can see, there is limited evidence to address the utility of cytoretinal nephrectomy in combination with ICI, which is primarily in the form of very small case reports and small institutional studies. In fact, I found one case report or one analysis done by Singla et al., who recently highlighted 3 case studies where patients experienced either complete response or radiographic response for nivolumab prior to cytoretinal nephrectomy. So after going through all this, what is the road ahead for us? What are we going to do? Let us look at the current status and the future direction, which will help us to plan our approach as far as cytoretinal nephrectomy is concerned in patients with metastatic RCC. Now, as I mentioned earlier, that choice of patient is extremely important in suggesting cytoretinal nephrectomy. In view of this, there is a paper done by Wing Liu in which he looked at the application of multidisciplinary algorithm-driven approach to treating metastatic RCC. This data suggests that patients suitable for cytoretinal nephrectomy could be identified through an MDT pathway that utilizes a combination of IMDC scoring, performance status, and metastatic disease burden. Now, their findings suggest that an MDT approach constitutes an important and viable strategy for the management of metastatic RCC, particularly in identifying patients suitable for cytoretinal nephrectomy. Well, the potential benefits of identifying patients are numerable. First, you are able to defer the onset of systemic therapy and its potential toxicities. And additionally, results also suggest that there may be a progression-free survival or overall survival advantage if suitable patients undergo cytoretinal nephrectomy. In the recently held ASCO 2020, Dr. Bakowny and his team assessed patients retrospectively who had been diagnosed with de novo metastatic renal cell carcinoma, and they had received first-line systemic therapy, either an immune checkpoint inhibition or targeted therapy, between 2009 and 2019. So they took around 4,600 patients who have been treated by targeted therapy and 437 patients with immune checkpoint inhibition. Both the groups had a set of patients who either received cytoreductive nephrectomy and some did not receive cytoreductive nephrectomy. What did they find? That the overall survival was compared between patient receiving cytoreductive nephrectomy and systemic therapies versus those treated by systemic therapies alone. To account for the selection bias, a propensity score was also used. What were their findings? First, they found that cytoreductive nephrectomy was more likely in patients with following characteristics. 1, less than 65 years old, no adverse metastasis, IMDC risk score of 0 or 1, and adverse histology, predominantly of non-clear cell or sarcomatoid features. On univariate analysis, cytoreductive nephrectomy was associated with improved overall survival in patients treated with either first-line targeted therapy or first-line immune checkpoint inhibitor therapy. Even the multivariable analysis and propensity score analysis demonstrated similar results. The p-value in each analysis was not significant. What is the meaning of that? Is that amount of benefit for cytoreductive nephrectomy did not differ between patients either treated by targeted therapy or by first-line ICI. Now, in spite of the possibility of confounders, the analysis demonstrated a significant overall survival benefit to cytoreductive nephrectomy, irrespective of the first-line therapy, and that cytoreductive nephrectomy should be considered only for select patients. But unfortunately, this is a retrospective study, hence the weightage of it is doubtful. But this has definitely triggered the intention of developing more prospective trials on similar lines, which would give us a better picture of how cytoreductive nephrectomy and ICI would help in patient management in the future. One more thing I want to include is the role of genomics in treating metastatic RCC. It has been postulated that molecular determinants of metastatic RCC may further aid in the clinical selection of candidates most likely to benefit from surgical resection, which also includes cytoreductive nephrectomy. But at the moment, they're experimental. Let's go to the most important trial. What do the guidelines say? EAU 2020 says do not perform cytoreductive nephrectomy in MSKC poor risk patients, but in case of low or intermediate risk patients, you have to weigh the pros and cons, stratify the patient, and then only offer cytoreductive nephrectomy. In the ASCO, there were recommendations made, and this is particularly important for the trainees as well. If you see, cytoreductive nephrectomy should rarely be performed in patients with poor risk disease, patients with rapidly progressive disease or high disease burden who need systemic therapy. Upfront cytoreductive nephrectomy should be considered in patients with favorable or intermediate risk disease who are candidates for active surveillance, or candidates who present with oligometastasis, intention or making with no evidence of disease status, or patients with kidney masses who are symptomatic in the form of hematuria or pain. Last is deferred cytoreductive nephrectomy should be considered in patients with strong responses to systemic therapy. So after going through all this, what should be our action plan, or what should be the take-home message which you should be taking home? First, there should be a cautious balance between perceived oncologic benefit and risk of intervention must be exercised when dealing with metastatic RCC patients and their treatment. Systemic disease generally needs systemic therapy. Therapy alone is not inferior. Cytoreductive nephrectomy remains selective. It should be individualized to patients. Patients like low risk and few intermediate risk patients can benefit from cytoreductive nephrectomy. As I mentioned before, multidisciplinary treatment approach where you risk stratify patients according to performance score, IMDC, and the tumor burden will help you to choose appropriate patients who can be offered cytoreductive nephrectomy. Of course, cytoreductive nephrectomy in checkpoint blockade NERA, as I mentioned earlier, need robust prospective trials. Some of them are in the pipeline, like the Nordic Sun trial, the CytoShrink trial, or the PROBE trial, which will help us understand the treatment options better. And last but not the least, patient safety is always the priority. Thank you for the time. Thank you so much.
Thank you, Dr. Santosh.
Thank you.
May I request all the panelists to please switch on their mics and videos. Dr. Hemang, sir.
You will have to.
Yeah. Okay.
Hi, I have. You want me to switch on the video? It sometimes hangs. I will switch on the video, but see how it goes. Yeah.
Okay. Sure. Yeah, it's quite fine, sir. So Dr. Nitesh will be.
Well, I think it was an excellent discussion and a very nice presentation from all panelists. And we have got quite a few questions on our Facebook. So we'll just go one by one and we'll try to answer all the questions so that it clears all our viewers' doubt. So first of all, the questions is in general, anyone can answer. It's not directed to one particular panelist. So anyone can answer. So first of all, what is the best investigation of choice for a patient who is having a atrial thrombus? Dr. Ginil is there?
Yeah, can you hear?
We cannot hear you, sir. You have to unmute yourself.
Yeah, I can hear you, Ginil.
Hello, can you hear?
Yeah, I can hear.
We can hear Dr. Nitesh. Can you increase the volume of your speaker, Dr. Nitesh?
Yes. Yeah, fine. It's fine.
You're audible, Dr. Ginil. Please go ahead.
Yeah, IVC thrombus, there's a discussion whether MRI is superior or CT is superior. That discussion was prior to the recent upgradation of the CT with MDCT and the quality CT which is available today. MRI and CT doesn't have much difference, but if CT is not actually clear about the upper level, I will go for an MRI. So if I want to see the upper level, like if it is very close with the hepatic vein, whether I can put a clamp below the hepatic vein, I want some extra investigation after CT, I'll go for MRI. If creatinine is not at the normal level, with the contrast CT, I may not get good pictures in the borderline level itself. So if creatinine is close to the cutoff level, then I'll prefer an MRI rather than a CT. So these are the points on which I'll decide about the investigation. Otherwise, at current day practice, MDCT and MRI are almost equal, and CT will give more idea about the vascular anatomy, like where the artery lies compared to the vein. So I'll prefer a CT, but if there is any confusion, I'll go for MRI. Creatinine is at the borderline level, I'll go for MRI.
What about the same thrombus if it is reaching up to the atrium? What will you prefer?
So in those cases, wherever I want to have a IVC clamping, I routinely go for a cardiac evaluation. So as a part of that, an echo is done. So that is one investigation. Other than that, another point is if there is any cardiac ischemia, I would like to tackle it along with the surgery of the IVC thrombus. So a cardiac evaluation will be done along with that. And on table, always in all thrombus above the hepatic vein, I routinely use a transesophageal echo. The anesthesia doctors will be doing a transesophageal echo in which they continuously monitor the upper level. And if there is any possibility of embolization or disintegration of the tumor, the cardiac patient will intervene even if the tumor is close to the hepatic vein.
Hemang Baxi, sir, do you do pre-op angio in all your cases where the tumor is reaching up to the atrium, or is there any criteria of doing pre-operative angiogram, coronary angiogram I'm talking about?
Not in all patients, but we had one patient who was symptomatic for, he was a 70-year-old gentleman, and he had some history of cardiac dysfunction. So the cardiologist recommended an angiography for it. We did that angiogram. He was found to have a double vessel critical block, and the cardiothoracic surgeons addressed it at the same time. They put in a graft, a CABG, along with the thrombus accession at the time of complete cardioplegia. So that is an advantage which you would have if you have. But all patients, so say I am dealing with a 50-year-old man, I would not do this. And one more point about CT versus MRI, a CT would also delineate pulmonary lesions and characterize them well. If there are small lesions suspected of metastasis, I think a CT would be a little better than an MRI.
So the patient who is having pulmonary thrombus, whether it's only bypass is sorry, sir?
Sorry, pulmonary arterial thrombus.
Yeah, pulmonary artery, if there is a thrombus, whether only bypass is necessary or whether patient have to go on complete circulatory arrest.
Complete circulatory.
So it adds
one case where it was a large thrombus just extending into the pulmonary artery, and surprisingly, because the patient was young, he tolerated that episode well. It did not lodge into the periphery of the vasculature and cause any significant breathing problems to him. So
extra morbidity is added of complete circulatory arrest.
Yeah, because the rewarming, when you do it, there are chances of all kinds of things happening. Patient can rebleed, he can go into DIC, he can go into CNS and other failures. But the best way of dealing with the thrombus, especially when the thrombus is a very large one extending into the atrium, you want a completely bloodless field. The best thing is a cardioplegia and complete circulatory arrest on a CABG pump. That really works very well as far as the thrombus accession goes. Now, it has its own complications after rewarming, but still, I would prefer that is the best way to go rather than, do a veno-venous, milk the thrombus down, trying to avoid it and doing it on a beating heart. Then you increase the complications of bleeding and other things. The only thing which you need to do very carefully while doing a complete circulatory arrest is you need to ligate each and every single vessel while doing the nephrectomy, because then you don't want anything to rebleed when the hypercoagulable state returns on rewarming.
Thanks. Dr. Rahul?
Actually, my question to Dr. Ginil regarding diagnosis of RCC. In cases of inflammatory mass, what is your take of doing a diffusion-weighted imaging MRI sequence to diagnose from RCC?
In inflammatory?
Yeah, suppose, there is a suspicion of whether it's an inflammatory mass or whether it's an actual RCC. So is there a role of diffusion-weighted imaging sequence MRI to determine either of it?
Diffusion weighted image in the pathological aspect, there are some discussions, but what we follow at this, I don't have much experience on that, but what we follow is if there is any significant doubt about inflammatory mass, we rely on the renal biopsy or aspiration and proceed accordingly.
My another question to all the panelists regarding a renography technique. One after the other, each one may contribute. It's a single layer, medullary, two layers, double layer, no suturing, any other techniques and their preferences. Maybe Dr. Ginil, you can start with.
Yeah, renography, that depends on each and every case. I decide about different strategy. When it is a closely hilar mass and in CT, the CT is very important. I can identify a particular vessel. I dissect intrahilar, try to get the vessel so that we can avoid avoid bleeding. And in majority of the case, when it is close to hilum, we may not be able to do the renography because the lip may not approximate. So in those cases, this strategy is very useful. And if the foci cannot be approximated, I could have a good suturing of the base of the fossa, where I can I can identify small vessels, and a good first layer can be done. lot of patients, I avoid a second layer rhinography because we have ischemia more in the second layer of rhinography. So if I'm not confident about the first layer, I sometimes put a second layer. That is usually when there's more in exophytic tumors than hilar tumor, because hilar tumor, I dissect both the intrahilar part, try to get the vessel, then go from the superficial aspect and enucleate. But from case to case, it varies. In open cases, what we do is usually majority of the case, what I showed the 12 tumor, actually majority of the case I do non-clamping. And if required in the last part only, I do the clamping. Even if I expect that more than 30 minutes of warm ischemia is expected after clamping, I put the ice, clamp, put the ice, and I proceed with the surgery so that I can just do the surgery and do the cooling at the surface cooling at the same time. That is my strategy grossly in robotic and open surgery.
Hemang sir, your take on this?
Okay, so if it's a small peripheral tumor, say 2 centimeters, outer cortex, mainly exophytic, I would avoid the second layer. But otherwise, in every single case, I do 2 layers.
Dr. Nitesh.
I prefer 2 layer in most of the cases, except for the hilar tumor where I cannot approximate the hilar lip. In those cases, I usually run a continuous suture on the hilar lip on one side. Otherwise, most of the cases, I prefer 2 layer.
Santosh, your take on this?
Most of the points have been mentioned by Dr. Baxi mentioned. It depends on the contact area of the tumor with the kidney. If it is small, and you're able to get away with just shaving of the lateral, the outermost parenchyma, or in cases where you do zero ischemia, and I would prefer to take only single layer. But otherwise, all cases would definitely be a double layer, and especially one case which Dr. Nitesh mentioned, which is absolutely right, because taking a second layer in areas near to the hilum would be tricky because you've got branching happening there. You don't want to damage any vessel at that juncture when you're about to finish the surgery. So I agree with that is another indication where I would take running sutures through the parenchyma and just approximate the parenchyma to block the acute vessels. That's my take.
Any difference in opinion, Dr. Srivatsa and Dr. Ragavan?
No, I think all points have been covered. Just to add, if there are very small exophytic tumors on the surface, you can avoid rhinography and probably just hypercoagulate, keeping the cautery settings, coagulation cautery settings at a higher level. So that will form a nice eschar and stop the bleeding, and we can avoid rhinography in those cases. Another tool that I have found useful in hilar tumors is the organ plasma coagulation. It is quite easily available in many centers where there are medical gastroenterology services available. It causes just a surface coagulation and prevents the bleeding from the bed. And like Dr. Nitesh said, you can just overrun the parenchyma to prevent the majority of the bleeding and use APC for the remainder of the hilar surface. The depth of penetration is not much, so the risk of damage to major vascular structures is very minimal.
I tend to do one layer, the inner layer first, and then open the clamp off. And for the outer layer, I do sliding clip rhinography. But if there is a larger area, I take a pediculated flap from the perirenal fat and put it inside the fossa and then close the geroda on top of it. That's what I've done both in open and robotics.
Anyone is doing doing partial nephrectomy without rhinography, like using various form of gel form or hemostatic agent or bandage technique, as asked by Dr. Vineet Gohar on Facebook?
I used to use the gel foam. I used to put always a bolster in between. Over time, I've realized that there is no need. If your suturing is good,
No, sir.
you don't need any gel foam or bolster at all.
Question is
And using that as a single, using bolster or a gel foam alone,
Yes,
instead of any rhinography at all, will not be very advisable.
I mean, the bandage technique, I went through the literature and saw it. There is a paper on Journal of Video Urology from a group. I mean, this is for a very small tumor, 3 centimeter exophytic tumor. They made a bandage out of a gel form, Surgicel, and thrombin and other materials, and they put it. But for such tumors, any technique can be applied as for. I mean, as of now, very few people are using, few papers are it. But yes, I mean, still the things are going on, and probably in some time we'll get some data. But basically for small exophytic renal masses, it is there.
So the next question is on PET scan. We see any patient who is coming with tumor that comes with a PET scan if he is referred by any physician or some other oncologist. So what are the real indication of PET scan in RCC? We'll start with Ginil, sir.
So actually, I had just put two cases in my case scenarios. PET scan actually adds more confusion than benefit in a lot of cases if we are doing it routinely. So indications are if there is any symptoms suggestive of any metastasis, or if obvious metastasis is there, or a part of re-evaluation or restaging when there is a small doubtful lesion. These are the indications for a PET scan. Otherwise, in the FDG PET routinely is not indicated in a renal tumor because a lot of inflammatory lesions, small lesions in the lung and elsewhere, like I showed in the acromion near to shoulder joint, an inflammatory lesion was brightened up. So these things can actually cause confusion in routine practice. So if you are expecting by any other, like if there is an alkaline phosphate elevation, if there is any symptoms, or if there is any doubtful lesion, there is a role for a PET scan. Otherwise, in the routine screening, there is no role for a PET scan in RCC. Because another factor is a lot of RCC, because of the metabolism difference in the RCC, may not take up the dye and they may not brighten up. A lot of primary may not take up the dye, and secondaries also may not be brightened up in FDG PET.
Dr. Srivatsa?
Sir.
So what is your take on PET scan and bone scan in RCC? When, what actually the guidelines say, when it should be done?
I think Dr. Ginil has already comprehensively covered it. We have to understand that, there is an argument that PET scan is not expensive anymore. And it's a one-stop solution for
in India,
because anyway you are doing a CT abdomen and pelvis along with a CT chest. But here, what I would like to highlight is the sequencing or the protocol that we use in acquiring images in an FDG PET scan is entirely different from a dedicated triple phase CT evaluation of the renal mass. So this is a common debate that we always encounter. So a PET scan uses a different variety of sequencing, and dedicated CT scan uses a different variety of sequencing. So almost like Dr. Ginil said, very, very selected indications, and probably also an added indication in suspected metastatic evaluation after a primary treatment has been done. Otherwise, I don't think there is much use for PET scan in RCC.
Dr. Ragavan? Ragavan, sir? We'll go to the next question. You do a partial nephrectomy and the margins are focally positive. What do you do next?
Sit and wait, because there is enough evidence to say that margin positivity itself will not increase the risk of cancer recurrence. What really matters in any oncology is the grade of the disease rather than the T stage. T stage matters only in local recurrence. Focal margin positivity is not something you need to worry about. However, if you have grossly gone into the tumor and left gross tumor behind, then the chance of recurrence is very high, or rather it will 100% recur. So focal margin positivity would not be a cause of concern, just a close observation. Of course, in a private practice, reassuring patients is a nightmare, but we have to reassure patients and tell them that we'll have a close observation for them.
Is there any role of TKI in these cases?
I prefer not to do TKI in patients who had partial nephrectomy. I have had two patients referred by a medical oncologist who had who I did a partial nephrectomy, and after that, the medical oncologist gave TKI as matter of fact. But what I realized is that one of them lost the kidney itself. because what happens is after you clamp and unclamp, there is definitely a lot of inflammatory change in the vasculature of the kidney for some time. So early TKI introduction probably causes some endothelial damage there, and I lost one patient, the full kidney itself, and I had to do a completion nephrectomy almost 1.5 years later. So in partial nephrectomy, when there is no evidence of metastatic disease, there is no role for TKI inhibitors at all, whether there is margin positivity or not.
One more point I want to add, Jain.
Yes, sir.
Is when we are having a positive margin, the follow-up protocols is slightly different. Guideline recommends a follow-up of almost like a T3 in these individuals rather than a T1.
Okay. Fine.
So what Ginil means is that you should be more intense in follow-up. Definitely some periodic scans. If you look at the follow-up protocol for RCC, it is almost 100% assured that we'll go nuts. There are so many CT scans. It's almost therapeutic radiation of those kidneys. What I've compromised myself is that I do a first CT scan, which will become the baseline. And after that, I get an ultrasound by a dedicated radiologist. Usually only 1 or 2 people do the ultrasound for me. And in T3 disease, in grade 3, grade 4 disease, or in positive margins, I do a CT once in a year. This is self-made protocol, but if you look at the protocols issued by EAU, it's almost say 6 monthly CTs, which I feel is too intense.
So many of these patients, if we do a very strict protocol and we are doing CT scan, but CT scan at times post partial nephrectomy is confusing. We don't know whether it's a recurrence or it is just inflammatory which is lighting up. So how do you overcome this?
I tend to do a CT scan exactly at 3 months from the first partial, which becomes the baseline for me to compare anything in future. Because usually you don't, by God's grace, you don't get super recurrences within 3 months. And 3 months is what the post-op changes are. And from that point onwards, that further CT scans in the future of that patient will become useful. From that point, if the patient has high risk factors, then they get alternate ultrasound and CT on a 3 or 4 monthly basis. So once again, every 3 months and every 4 months does not make a difference, but the number of scans will come down. If the patient has low risk disease, then only ultrasound is the only follow-up technique I use. But the idea is that it has to be done by a reasonably dedicated guy who does this often. Otherwise, if the patient walks into a scan center and does a CT or an ultrasound, they will come back with a very scary report.
Yes.
With the gradual experience with the minimal invasive techniques being done in partial nephrectomy, the margin positivity is getting lesser and lesser day by day. And also the intraoperative imaging techniques like intraoperative ultrasounds. The chance of being a margin positivity is definitely less. But yes, for central tumors, if somebody is suspicious, can send a frozen section, wait for some more time, and then probably go ahead. But with an experience, even if we cut through the tumor, the surgeon used to know that it is the tumor which he is cutting rather than the actual parenchyma. So all those things can add upon to actually not get a positive margin.
I completely agree. What really matters is the surgeon's experience. More you do, better you get at it. And therefore, for all budding surgeons who are doing these surgeries now, I would strongly recommend that have a senior with you so that whatever you do, there will be a course correction intraoperatively itself. But even in the most experienced head, you will get a positive margin. My guesswork is that roughly it's about a 1 to 2% of all your partials you'll get positive margins. There is also a lot of confusion in the positive margins. So we used to have a big debate with our pathologist. So if you go into, if you take a tumor that is going into the calyceal system, there are no parenchyma to go beyond that cut point. It's a dead space. So if the tumor is extending up to the calyceal point, then the pathologist will say tumor is extending up to the point of resection. So what I have realized and over time, what I have made them do is that I clearly ask them to mark whether it is extending in the interior or exterior and the circumferential parenchymal extension of the cancer. That's why I prefer not to do enucleation. even though the reports are, there is a lot of reports suggesting enucleation is as good as partial. I try to give at least a few millimeter margin around the kidney, around the tumor, at least in the cortical area.
So, Dr. Santosh,
Yeah. Hi.
is this message clear that cytoreductive nephrectomy can be done for low and intermediate risk patient after Carmina trial, or it has added more confusion? Can we do cytoreductive nephrectomy or not?
So as I mentioned in my presentation, that in low risk, definitely yes, but you need to take into consideration, you have to risk stratify the patient, look at the features which he has. An intermediate risk, you have to weigh the pros and cons, whether the patient can undergo cytonephrectomy or no. But in low risk case, yes, the patient can be offered cytonephrectomy. That's what the last recommendation in ASCO was also there. But the confusion is there because with newer treatments coming up and newer trials being proposed, so this concept will definitely be changing over a period of time.
There is a lot of confusion about cytoreductive nephrectomy. I want to tell a few points. If you have an IMDC risk criteria high, then doing cytoreductive nephrectomy is unlikely to add value to the patient. So if at all there is only one thing in Carmina trial that is very important, is that IMDC high risk criteria will not benefit with cytoreductive nephrectomy. That is one take home message that we can be clear about. Rest all is waffle. In the low risk criteria, if you are going to do cytoreductive nephrectomy and add some TKA after that, they are likely to benefit. An intermediate risk is purely a discussion. Nobody actually knows anything. My own experience and my own thinking is that if you have a young patient with a good performance status, they inevitably will want a cytoreductive nephrectomy for debulking purposes, provided the extent of metastasis is very low. There is another point, point that Ginil mentioned about a PET scan showing a humerus uptake. So at this point, I want to make it very clear. The PET scan is being done by GPs and medical oncologists as if it is chest X-ray, which is very sad. So what happens if you do PET scan is that you are going to pick up all these mild abnormalities which we do not know whether they are malignancy or not. Please do not exclude your patients off based on those PET scan. Do corroborate those PET scans with an MRI or something else in order to make sure the patient gets the benefit out of a nephrectomy. There is no replacement to nephrectomy in terms of a good local control and symptom control for the patient, and probably curative as well. So I have seen, at least in my experience, I've had 3 patients with dubious mets in PET scan, which turned out not to be the case after I've done a corroborative MR scan, gone ahead and did nephrectomies for them. All of them are doing well. So beware a lot about PET scans, especially in a cytoreductive setting.
Dr. Ginil, there is a question for genetic tests. What are the genetic tests available? What is the cost of the test? And whether it should be limited only to the index patient, or they should be done even for the siblings and children?
Actually, when the patient has multiple tumors in a family history or in a young individual, we just combine with the genetic counselor and decide about the genetic screening. Regularly, if the history is evident, like VHL and all these things, the genetic screening is very easy. But there is the genetic screening actually detects almost all the genetic abnormalities as a screening procedure, and the cost comes to something between 20 to 25,000. It is done from outside and actually not inside the hospital for us. It is sent to outside for specific centers. So this is what we are doing.
So finally, one question for everyone. What are your tips to decrease the ischemia time during partial nephrectomy? Yes. Yeah.
Practice. And always do a thorough inner layer suture and take the clamp off. But for you to do that unclamping after a good inner layer will come with only with practice. So for novice beginners, do 2 layers and then off the clamp, but do them quickly. For reasonably experienced, you can take the clamp off as soon as the inner layer is done, because inner layer clamp off means you will be taking the clamp off in 17 or 18 minutes, which is the best ischemia time you can get. But nothing can replace practice, and definitely for the first 20-30 cases, have somebody with you when you're doing that.
So
Yes.
Santosh, please.
Nitesh, there was a question raised by Dr. Aditya Pradhan, and he wanted to know what is the take on, and I would probably open it to all the people, all the speakers here. What is the take of giving TKI in a case of IVC thrombus or a supradiaphragmatic IVC thrombus? Personally, my experience in if I get a patient of an IV thrombus, I'll definitely upfront off. But the case report mentioned by Dr. Baxi is definitely encouraging, but since it's a single case series, we need some more data on it to really validate the use of TKI. But I would love to have the panelists' view on this. And my second question to all the panelists is, after doing an IVC thrombectomy, whether open or robotic, do you send the cut margin of the renal vein, cut margin of the IVC to see that it is free of tumor? Because that's a dilemma the pathologists do create, and sometimes they say the margin is positive, it's involved, but it is not, we know on gross. So what's your take on it? Thank you.
Okay, so first thing, TKIs and downstaging, I already mentioned. We should not be doing it. In simple answer, one word, the answer is no. You should not be downsizing or hoping to downsize a tumor. There is enough literature on this, of course, small series, but everyone says that the benefit is not that great. So do not use TKIs or any other form of medical therapies for downsizing renal thrombus, even if it is level 3 or level 4 or difficult to operate. You should not be doing it. That case I mentioned was just an anecdotal case, so you can't really extrapolate that. Regarding the renal positive margins, yes, we do get, even with level 1 thrombus, sometimes the cut margin is positive. You have done a good resection, the vein is focally involved. IVC margins, we don't send it separately, but if they at all come out positive after the surgery is done, we just observe. I mean, that's what we do. I would love other panelists to have their opinions.
As a protocol in our pathology department, we routinely ask them to have the cut-end margin, to check the cut-end margin. But pathologists always, when at the tumor can be at the tip, when there's one confusion that can happen. So we insist on checking the IVC margin rather than putting the tumor is extending up to the cut margin, because the tumor obviously will be there at the cut margin. So that is one thing we insist. When the margin is positive, actually few patients we have started on TKI as an adjuvant, because why we are putting is that even though there is no data on TKI as an adjuvant, only trial which specifically looked in this matter is the extract trial, where they have actually, if there is any cut-end positivity, they had included these patients. So in that trial, actually there was a benefit. Based on that, we just suggest TK, but if the patient can afford and if the side effect is not that much embarrassing, we put them on TK for 1 year. That is what we do if cut margin is positive in IVC, if the IVC cut margin is positive. Second option is just to intensely monitor them like a T3, like every 6 months to have a CT. That is the second thing we do. And we have a tumor where there was a recurrence in the IVC. We resected along with the Whipples we had to do. So that those aggressive treatment we go on if there is a recurrence in selected individual if there is no metastasis.
Want to add more on this?
Yeah,
Dr. Nitesh.
Yeah, you go ahead, Dr. Rahul.
Anybody want to add more over this? point is well taken. Okay. There is one question from Dr. Himesh Gandhi. For hilar lesions, role of dissection by entering in gilvernal plane using a gauze.
I used to do a bit of hilar dissection. Thing is, if you are dissecting with gauze, the issue is there will be a lot of collateral veins, the flimsy veins will be there. So we under vision dissecting the area is more preferable to me rather than a gauze dissection, because compared to the other condition, in this condition there will be small minute veins that can break, and further the dissection will be completely will be very difficult if we are doing a gauze dissection, gilvernal dissection. But probably in selective individual, if there is no increased vascularity, that may be an option. But I prefer to dissect under vision.
Hemang sir, your take on this?
I've never tried the gauze dissection, so I really cannot say.
As Ginil said, if you're going to go why do you want to go into Gilverney plane? You want to go into Gilverney plane either if you want to do a zero ischemia, or you want to go to Gilverney plane because it's a very hilar tumor. So I would strongly do not recommend zero ischemia for people who are starting to do partial nephrectomy. Probably, I'm not sure whether Inderveer Gill himself is doing it anymore. So moving on to hilar tumor. Now, what you need to dissect is the tumor. So you go into the root of the artery and vein wherever you want to clamp. Make sure they're isolated and well. Because as you go proximal to the vein and artery, you will find that you are capturing all the branches as well. Inevitably, there is usually a single stem, unless you have a separate origin of an artery or a vein, separate veins and arteries. So you will be able to capture the stem right at the point where they are originating or inserting. And once you have captured that, you go to the tumor and follow the tumor, rather than dissecting the Gilverney plane. And using gauze piece or any other blunt object in that plane, as Ginil rightly said, you inevitably find small vessels that are coming and going into the renal vein, and they will start to ooze, and then you have to pack, wait. Some novice people will put a stitch as well. You just are adding, and I've seen at least one of my colleagues where the renal vein went into thrombosis as well. So you want to keep those things at the lower side. So go to the root of the artery and vein, capture there, go around the tumor for partial, even in the hilar tumor, you'll be able to take it out.
So most important point in partial nephrectomy, what I will say is a clear examination of the CT film is the most important factor, because the vascular anatomy, how you have to proceed, how you have to dissect, everything depends on how you analyze the CT. So a good CT, if it is not clear, repeat the CT is the first step I will do if I am planning for a partial nephrectomy.
Nothing can replace a good quality triple phasic or multiphasic CT, because it tells the story to you, the depth of the cut, the amount of arteries, veins, the flow of the thing, where you want to put your ports. If you're doing a robotics, where you're going to put your ports, the CT tells the story. Whilst from a diagnostic point of view, CT and MR will be same. Nowadays, that's what people and reports are saying. But MR can never give the vascular anatomy the way CT does.
To conclude, I'll thank all panelists for giving an excellent talk on each and every topic, going into the great detail of it and giving the abstract from the summary of everything. I mean, people have really praised for all the panelists in our Facebook ULTO group, saying excellent presentations by all. Thank you all for oozing out time for the talks. Thank you.
Thank you, and thanks. Well conducted and well done. Thank you so much. Very appreciable.
Stay safe.
Thank you. Thank you.
Thank you, guys.